We are going to start in about 4 minutes. Can you just put some captions up on the screen, just so we can make sure it's good? Thank you. Yep. All right, we're good.
Hi, everyone. Ooh, that's really strong. We're going to get started here in just a minute. So can I ask the first session speakers to come and join me on the podium? And we're also going to hear from one of our sponsors of this fantastic event to kick us off. So we're going to get started in just a minute. Thank you.
Good afternoon, everyone. My name is Timothy Higdon, and I'm the president and CEO of Hearing Health Foundation, and I want to welcome you to the Meniere's Disease Symposium. This is a program that has been in planning and thought for quite a while, and we're really thrilled to have all of you here. I want to take a moment to thank our sponsors. Spiral Therapeutics and Scott Dorsey have sponsored the symposium. Our co-hosts are the American Hearing Research Foundation, Cures Within Reach, and the Vestibular Disorders Association. And we've been working together for, I think, about 9 months to pull this together. I also want to take a moment to thank a couple of our Meniere's disease major donors that have really supported the research. Carrie Kopazinski, who's here, the Salas Family Foundation, and Karen Coley. And I also want to acknowledge a couple of the HHF board members who are here, Paul Orlin, Judy Dubno, and Carrie Kopazinski. So there are 2 sessions this afternoon and a reception that will be in the back afterwards. Everyone should have gotten a drink ticket for that. And at the end of this symposium, there'll be a QR code where we'll ask you to, well, the QR code's right here. Please fill out the survey and let us know what you think. So without further ado, we'll get the symposium started, and thank you so much for coming.
Hi, everyone. My name is Claire Thibodeau. I am the Vice President of Scientific Affairs at Cures Within Reach. We are so excited to be with you here today. I think we're going to have a really great symposium to talk about Meniere's disease, from clinical applications to research, and to get us started, we're going to be hearing from a Meniere's disease patient. Cures Within Reach began funding research in this space in about 2018, and we've really seen that this is an area that needs a lot more research, that needs a lot more attention, and we're really pleased to see everyone here who shares that belief and is as interested in solving Meniere's disease as we are. Again, I want to thank Hearing Health Foundation and the American Hearing Research Foundation for really being the driving force behind this symposium today. So we are all here because we want to help patients who have Meniere's disease, who suffer from this condition. So I think it's only fitting that we begin our symposium today by hearing from a patient, Heather Davies, and hearing her experience in perspective. Heather?
Imagine the sweet chatter of your 3-year-old daughter's voice penetrating your ears with such painful intensity you have to wear earmuffs just so you can tolerate being close to her. Imagine your hearing begins to fluctuate in one of your ears, and then the roaring, hissing tinnitus in both, knowing all too well what comes next, the uninvited visitor vertigo. Within moments of thought, you're on your knees, gently guiding yourself onto your stomach, and finally resting your face on the hardwood floor. One hand outstretched in front of you, as if to stop the sensation of a never-ending fall. Your eyes fixated on one spot. Today, it's a spot far underneath the entertainment center. Your eyes fixated on this. Without breaking your gaze, you move your hand backward and breathe a sigh of relief. Your daughter's found her way to you. After all, this is a game she's played daily for nearly 6 months. Your back-stretched arm cradles her against your waist, and she's content playing with her Olaf stuffies and dinosaur on your back. As you breathe a sigh of relief, she's unaware of the torment you're experiencing. As a wave of nausea comes over you, you're exhaling slowly, not blinking, not moving, praying the vertigo passes quickly and takes tinnitus with it. As you remain calm, slow breaths, questions pass through your mind. Is the stove off? Is the baby gate locked? The spinning's faster now, and you're just praying to God that it stops. Your eyes still fixated on that one spot on the wall. As you fight back tears, no, not the tears, you start your mantra, I'm safe, I'm steady. Inhaling now, you breathe in calm. Exhaling, I release fear over and over to remain in a place of peace, knowing that this will pass. Imagine this lasting for 2 hours, 4 hours, sometimes 6 hours or longer. I don't have to imagine this insane reality because I lived it nearly 6 months in 2016 and 17. My name's Heather Davies, and this is just one of many stories I have living with Meniere's disease. Today I'm an ambassador at VeDA and host of the Meniere's MUSC podcast, where vestibular warriors come on and share their very honest stories living with Meniere's disease, obstacles they've overcome, and ones they continue to live with on a daily basis. I was living a very full life when Meniere's burst into my world. I was stepping into my 18th year working as a psych nurse, running fitness groups, while also caring for my 15-year-old son and 3-year-old daughter. I had no white space on my calendar, and yeah, I was burning the candle at both ends. I began experiencing some numbness and tingling on my head that went down my face, and I just pushed it off as stress. I'll deal with it. And it continued to happen, and I promised my mother if it happened again, I would go to the emergency room. Well, it happened again. After many tests, they came back and told me I had a brain tumor, which that's all I heard after that, brain tumor. Although I was initially fixated on the meningioma being the cause of my symptoms, I just knew it was the root. It turns out it was just an incidental finding. So off we went to figure out what was going on with my body. We visited over a dozen doctors, various specialties, but it wasn't until I went to a multidisciplinary clinic where I was finally diagnosed with Meniere's disease and vestibular migraine. So once the beta blockers and diuretics began lessening the vertigo, I attempted to return to work with accommodations. I was unable to drive, so I had to be escorted to my patients' homes, and I worked as a psych nurse, so I gave a lot of long-acting injectables. I began to question myself, second guess and triple guess myself to the point it simply wasn't worth the risk for my patients. So I stepped away from nursing, and I lost myself completely. I lost complete confidence in myself. I didn't know how to be anybody that wasn't a nurse. Been doing it for so long. I lost my complete identity. In between doctor's appointments, I would spend my day cooped up in a dark room. Sorry, still wrong. I apologize. I didn't get many visitors, and I had a visitor one day. A friend came into the darkness, and she sat on the side of my bed, and she said, I don't know what's going on with you. I'd like to understand, but it seems like you've given up. So maybe you should start dreaming another dream. Those words hit me so hard. So as I watched her leave, pulling the door closed behind her, those words hit me hard. Dream another dream. I never thought of the dreams that my husband and I built together never happening. Until that very moment. So that thought never crossed my mind. I never thought of this disease taking our dreams from us. Her words landed like a gut punch, and but it also shifted something inside me, raw and unyielding, and it made me want to figure out how to live my best life with this disease. So the journey started, and I was determined to live my best life regardless. Our dream was to wait till my son graduated, buy a sailboat, sell our home, 90% of our belongings, and set sail. So in the wake of my friend's statement, I realized I had to figure out and make that happen. So the journey began. It was one of deep self-reflection, taking a step outside of myself and looking at the bigger picture, how I was living my life and how I could make the best of what I was dealt. I was working a full schedule with barely getting 5 hours of sleep a night. I rarely listened to my body. So I had to figure out how to trust myself again. And so the reinventing began. I began to mourn my previous life while learning to navigate a new one. It is one with less rigid schedules and a more of a go-with-the-flow mindset. It's balancing hope for the best while also planning for the worst. And I still do that today. I began making changes spiritually, physically, mentally, and nutritionally, and I started to regain control of my life. If I have a bad day, I will go outside, and if it's doffing off our bow, or birds singing, or simply the sun on my face, and I remember those little glimmers of hope, and that life is still good despite the symptoms. There are so many Méniérians with heartbreaking stories. In the time that I've been diagnosed, one in our community has taken her life, and 2 others have attempted theirs. And these are just friends that I know of. But these 2 ladies are now, with the support they've received in the vestibular community, are strong voices. And I must say that one of the most powerful aspects of navigating life with Ménière's is the sense of community that you get from all involved. I had the privilege of collaborating on a project called Dear Ménière's. I don't know if any of you have heard of this book. There are hundreds of letters here to Ménière's, and there are photos of artwork that all Ménière's patients have contributed to this book. All proceeds do support Ménière's research. It is raw, real, and heartfelt. It is not for the weak. It is a beautiful book, but there's a lot of emotion inside of this. Early in my journey, I was searching for reassurance. What I needed to know was hope. I needed hope in order to move on. And while walking one day and listening to a podcast, I wondered if I could do this. I wondered if I could create a space for vestibular voices, for people to share their stories, obstacles they've overcome, and ones they continue to live with. And that's when the Ménière's Muse podcast was, when it started. A lot of the guests have left corporate jobs to find themselves to coaching vestibular warriors to live a normal life as they can. Others have created apps for the community. But it's through that shared vulnerability, laughter, and tears that we're able to move forward and chart a course toward hope for ourselves. Listeners are finding strength in knowing they're not alone. And that's what a lot of us need, is to know that we aren't alone and to hold on to hope. I've expressed many times in the podcast that Ménière's has been both a blessing and a curse for me. A curse being the physical and emotional pain, the loss of my independence, the impacts on my relationships, and of course my career, and the uncertainty of it all. A blessing which cannot be found in the depths of the darkness. Through greater self-awareness, stronger connection, advocacy, and the purpose in supporting others. A common thing among vestibular warriors are those tiny blessings, those little glimmers that you can find every single day, whether you're having a good day or not, just the tiny little ones that make it all worth it. This is not, of course, to minimize the bad days. But when I was diagnosed with MD and VM, my world quite literally turned upside down. I lost my balance, my sense of control, and often my hope. But along the way, I also discovered a resilience I didn't know I had. I found a community of people who helped me navigate this uncertain journey. This illness is undoubtedly a curse. It's relentless, unpredictable, and isolating, but in the darkness I did find light. It pushed me to connect with others, to advocate for awareness, and to find meaning in those small victories. It became a catalyst for my personal growth and deep empathy. The research that you do, the treatments you develop, and the hope you give is part of that light. For people like me, your efforts remind us that while we may be navigating an unsteady path, we are not alone in seeking solutions. Your work isn't just about curing symptoms, it's about giving hope. And I hope each of you realize that. Every patient you see, every study you complete, every small advance in understanding brings us closer to a life where we can embrace the blessings over this curse. So I stand here today as proof that while chronic illness takes, it also teaches. And with your continued dedication, I believe we can turn the tide, creating a future where blessings far outweigh the curse for everyone navigating this journey. I thank you for your dedication and for being a part of this journey with us. Thank you.
So we have a couple minutes for questions, if there's anybody in the audience that has any questions for Heather today. We have mics in the center. Please feel free to go to one of the mics if you have any questions, either for Heather or for any of our other presenters.
I have a question. Do I have to push something?
I think so.
No, it's not working. Oh, it's working. Heather, one of my patients gave me that book. It's actually a pretty good book and has a lot of good testimonials in it. I have a question for you. What symptom was the most affected most your quality of life? And is the hearing, the balance, both? And if you were to choose one to get rid of, which one would it be?
Honestly, once the vertigo of course, but the hyperacusis is my most debilitating. Having a 3-year-old, now 11, where I was unable to tolerate being close to her. That was the hardest. And aside from the vertigo, yeah. The hearing loss, I can deal with, but it's really all a matter of perspective. I really believe that. I know that my hearing is going. It's just something I'm going to have to deal with. And but on a day-to-day basis, if I were to ask for one thing to be gone, because my vertigo's not constant anymore, is the hyperacusis.
I think we have a question in the back.
Thanks, Heather. I have a question for the audience. There was 211 people here that were signed up. Anybody here raise their hand to say whether they have Meniere's disease or not?
I didn't understand.
Yeah, I didn't hear it. Couldn't quite understand that question.
The question is that how many people in the room have actually got Meniere's disease?
Oh, from Meniere's disease.
Heather, I think that's a very, very brave thing to do, and I'd like to thank you for that.
And
I still didn't hear, but okay.
Who has Meniere's disease?
yeah, sorry. Yes, the question was who here has Meniere's disease? Any other questions for Heather before we move on? Well, Heather, thank you very much for sharing that story, your experience, very powerful, and I think a great way to frame the rest of our discussion today. So next up, we have Robin Bigelow, who's going to talk about Dr. Robin Bigelow, the history of Meniere's disease, to give us some historical perspective.
Good afternoon, everybody. Thank you for inviting me to speak here, and thank you for sharing your heartfelt story. It's an important reminder of why we're all coming together today and what we're working towards, trying to help people suffering. Today I'm going to be talking about the history of Meniere's disease, looking at different surgical management strategies for Meniere's disease that have been tried in the past 150 years. I have no relevant financial disclosures. The objectives, I'm going to talk about some historical accounts of individuals who may have had Meniere's disease, a brief history of Prosper Ménière, and reviewing a kind of timeline of different surgical therapies that have been trialed for Meniere's disease. A couple early descriptions of Meniere's disease. This first one is about Martin Luther, who's famous for the 95 Theses. In 1527, he described having roaring tinnitus in the left ear with a state of sickness and collapse followed. After a night's rest, all the symptoms subsided except the tinnitus. Similar attacks with increase of the tinnitus and vertigo seized him at irregular intervals and distressed him extremely. He thought that the devil was chasing him, and he was so frustrated he was known to throw his inkwell across the room. Sounds like a possible description of Meniere's disease. Another notable historical figure who possibly had Meniere's disease is Jonathan Swift, a famous author from the 18th century. He said, "I got my giddiness, then I got my deafness, and these two friends, one or another, have visited me every year since, and being old acquaintances have now thought fit to come together." Descriptions of vertigo have been present in medical literature as far back as medical literature exists. In Egypt and Greece and Rome, dizziness and vertigo have been thought to be due to a seizure or stroke and related to changes in blood flow in the brain previously. That was until Prosper Ménière came around. He was born in 1799 in France, and after medical school, was eventually appointed as the director of the Institute for Deaf Mutes in Paris, despite having no prior training in otology. He died in 1862, just 1 year after his famous contribution to otology. He was a bit of a Renaissance man and had many interests outside of otology and medicine. He published multiple papers about orchids and was a lover of the opera and literature, and also published on the historical understanding of medicine from Greek and Latin poets. His landmark presentation, for which he's famous for, was in 1861. He presented to the Imperial Academy of Medicine. He argued that vertigo and hearing were linked to each other and could result from inner ear disease. This was a dramatic departure from the previous understanding of vertigo as related to problems in the brain. As evidence, he described several cases, vertigo and hearing loss happening after penetrating ear trauma. There was a young girl who had vertigo prior to passing away, and on autopsy, they found blood in her labyrinth and inner ear, but none in her brain. He described a symptom complex, which is now known as Meniere's disease, and saw a number of patients who experienced fluctuations in hearing loss, tinnitus, and dizzy spells, and he described how after the hearing was gone and the fluctuations decreased, patients no longer seemed to experience vertigo, which is similar to how we think about Meniere's disease often burning out. This quote will lead us into the next section talking about treatment for Meniere's disease. The number of treatments available for a condition is inversely proportional to the success of those treatments. I first heard that from Gerald Brackman, a giant in our field. And I think it's appropriate in Meniere's disease. We have, over the past 150 years, tried many different things, and currently there are many different treatment options available, and none of them are especially successful in everybody. So what did people get in the time of Prosper Ménière? Medical treatments included quinine, dyspeptic treatments, and iodine of potassium, as well as taking Turkish baths or being exposed to sulfur water. Procedural treatments included bleeding or leeches, a seton to the neck to produce pus to balance the humors, or moxa, which is an ancient Chinese remedy of burning cotton and placing it close to the skin to balance heat and cold. Ménière himself didn't much believe in these treatments and said it was, to paraphrase, kind of a travesty, and often the treatment was worse than the disease. Looking at the medical literature moving forward, one of the first major textbooks, Principles and Practice of Medicine by William Osler in 1900, not many changes. He still recommended iodine, potassium, salicylates, and quinine. Another textbook from the early 1900s by Edward Dench recommended bloodletting. Considerable blood should be abstracted from the mastoid region by means of a wet cup. Bloodletting is permissible when the attack is of unusual severity. Wet cupping is making a cut in the skin and then putting a negative pressure cup to draw blood out. A number of early surgical attempts at Meniere's disease are summarized here. Perry divided the eighth nerve intracranially by a middle cranial fossa approach, often leading to facial paralysis and several mortalities. Crockett removed the stapes, which led to deafness. Milligan and Lake opened the semicircular canals and instilled an antiseptic, an early attempt at a labyrinthectomy. Babinski, famous for the Babinski reflex among many other advances in neurology, advocated for lumbar puncture and said it was moderately successful. Jenkins would decompress the horizontal semicircular canal and similarly said it was moderately successful. Another text from the time, 1914, by Ballinger, recommended pneumomassage, or suction of air in the ear canal. This relieves pressure upon the foot plate and can be performed by placing a rubber tube from the mouth into the ear canal and sucking and blowing intermittently. This idea lasted for many decades and actually led to the development of the Ménière device, which was used several decades ago and fell out of favor. And another textbook, Dr. Ballin recommended cold compresses, sponge baths, an early mention of the importance of diet in managing Meniere's disease. He recommended avoiding alcohol, tea, and coffee. He injected potassium iodine into the tympanic cavity through a eustachian tube catheter, and electric treatment to the head. Electricity was used for a number of different medical treatments at the time, and it was kind of in vogue and used in most medical disciplines. They would instill low current electricity across the head, and it was said to be moderately successful. Portman in 1926 had the first description of an endolymphatic sac surgery. Here are some diagrams from the original publication demonstrating a mastoidectomy being performed with a gouge. The surgical steps are similar to how endolymphatic sac surgery were performed until today, with decompression of the sigmoid and posterior fossa plate, and Portman advocated for opening the endolymphatic sac with a needle. Walter Dandy was a famous neurosurgeon who had many contributions to the field. He advocated for eighth nerve section for intractable Meniere's disease. This was successful in treating vertigo episodes, and hearing could be preserved in many cases. Bilateral nerve section led to Dandy syndrome, or bilateral vestibular hypofunction, which can be fairly debilitating. And in his first 400 cases, there was only one reported death. Interestingly, in his text, he described doing a suboccipital approach under just local anesthesia in the majority of cases, a little different from today. A number of other destructive procedures were proposed for treating Meniere's disease. Wright did a transtympanic transoval window injection of alcohol. Mollison injected alcohol directly into the labyrinth. Cawthorne did a transmastoid labyrinthectomy. Goodyear opened the horizontal canal and scraped and cauterized the membrane. And Day did a similar procedure using electrocautery to neutralize the inner ear function. An interesting paper from 1948 advocated for division of the stellate ganglion and sympathetic trunk, as well as the vertebral artery. The authors said, while it may be risky and potentially cause a stroke, the risks were low because most Meniere's patients were young and healthy. The other authors at the time disagreed with him, and the sympathetic neurectomy was popular for a number of years, but the medical literature appropriately did not support his advocation for vertebral artery ligation. Several doctors in 1951 were doing the first transtympanic injections. Currently we do transtympanic injections of corticosteroids or gentamicin for treatment of Meniere's disease. Back then they were injecting cocaine, tetracaine, and alcohol. They described patients getting severe dizziness 20 minutes after the injection. Medical literature was not as rigorous in its standards back then. I wanted to put a direct quote and picture of the results section of their paper here. It says, of the 37 patients selected for injection, good results were obtained in the majority. And that's it. A frontal lobotomy was in vogue in the middle of the 20th century. There's a case series of 20 patients who had tinnitus, many of whom were reported to have Meniere's disease. A frontal lobotomy is a procedure to destroy the prefrontal cortex. There was one death, 8 people improved, and 11 had no change in their tinnitus. There was a nice quote from this that I'll summarize, where the authors described the patient said the tinnitus was no better, and she had behavioral problems and inhibition problems, but she was happy because it didn't bother her that much anymore, and the husband was happy because she didn't bother him much anymore. This is a nice diagram from Brian Ward's paper describing several endolymphatic surgeries that were done in the 1960s. I encourage anybody interested to look it up. There are some interesting and clever ways that physicians at the time tried to manage the dilated endolymphatic space that we know is responsible, or at least a part of Meniere's disease. In 1962, William House described the endolymphatic shunt. This is a modification of Portman's endolymphatic sac surgery before, where the similar surgical steps were performed, and instead of just opening the endolymphatic sac, a foreign body was placed into the endolymphatic space to keep it open. He published on this a number of times and described good success. So how does Meniere's disease relate to the moon? Alan Shepard was the national hero when he was the first American who was sent to space. Unfortunately, 2 years later, he developed Meniere's disease, and he suffered greatly. Medical therapy, including diuretics and niacin, were ineffective. He did his research and heard about Dr. William House, and in 1968 had a shunt procedure done. 6 months later, he said he had no more symptoms, and he ended up flying to the moon with Apollo 11 several years later. That concludes my very brief history of some of the surgical treatments for Meniere's disease. There are many more. If you're interested, you can dive deep into the history. I think it's very interesting to look at where we've been in the past in treating this challenging problem. It puts in perspective, people back then were doing their best. Currently, we are doing our best. 50 years from now, we're going to look back at this time and think, why couldn't we do better?
So we do have some time for questions. Anybody in the audience, if you have a question, please step to one of the mics, or any of the fellow speakers up here, please feel free to use your mics here for any questions.
Everyone, so what are we doing today that you're going to include in this talk in 20 years?
I mean, do we know, gentamicin work, if you ablate the inner ear, that works. Do we know how well oral steroids or intratympanic steroids work in a systematic way? I think anecdotally they certainly do. Same for diuretics or dietary change. I think anecdotally in individual cases, some people respond to certain things very well. But ideally, if in 20 years and 50 years, we'll have a better understanding of Meniere's, and we'll have Meniere's type A, B, C, and D, and we can appropriately put people into the right category at the onset and figure out what treatment would work for Meniere's A versus Meniere's B.
Any other questions? Thank you, Dr. Bigelow. So now we have Dr. Habib Rizk, who's going to talk to us now about maybe some more modern treatment options.
Thank you, Claire. Good afternoon, everyone. I'm happy to be here and talking to an audience that wants to listen about Meniere's disease. So I was tasked to talk about the current clinical care and standard treatments that we use and address the topic of potential unmet clinical needs. These are my disclosures. This is the outline of my talk. I'm going to review quickly the Berlin American Academy criteria for Meniere's. I'm going to talk briefly about the migraine overlap. We're going to discuss some of the care gaps and the standard and off-label treatment. And finally, I'm going to talk about clinical trials and what we can do better to improve our research and find cures for this disorder. In 2015, the International Classification of Vestibular Disorders changed a little bit and simplified the diagnostic criteria. And for definite Meniere's disease, we know now we use the following criteria of having more than 2 spontaneous episodes of vertigo lasting between 20 minutes and 12 hours, with fluctuating otologic symptoms within 24 hours of the episode, as well as an audiogram showing a mid to low frequency hearing loss in 2 consecutive frequencies. The 2020 American Academy criteria kind of followed the same format. They simplified a little bit of the very strict audiometric thresholds that were discussed within the Berlin consensus document. And they issued 2 statements. Statement 1 about using this current more modern criteria to diagnose the disease, but also statement 3, which sounds self-evident, is obtaining an audiometric testing before making the diagnosis. And that speaks to how many patients sometimes carry that diagnosis and they've never had an audiogram. The other question that is asked, is there a role for imaging in the diagnosis of Meniere's disease? And in the guideline document, it was an option to obtain imaging, an MRI. And while certainly an MRI of the internal auditory canal is an option in typical cases, something needs to be said about the advent of MRI high drops, and I'll leave it to my next speaker to talk about that could potentially close a gap in the diagnosis. When we look at what we currently do in clinic, most of what we do has absolutely no evidence. I mean, the guideline recommend dietary and lifestyle modifications because it's a tool that has been shown to work with some patients. We don't have the evidence to support it, including with the very recent Cochrane database that was published in 2023. The same goes for the pharmacotherapy we use, whether it's diuretic or beta-histine. The guideline issued an option for those treatments to be used, even though we have a low quality evidence of the effect of beta-histine on vertigo. And the most recent systematic review published at the Cochrane website in 2023 also showed that there's absolutely no evidence for oral pharmacotherapy. And it doesn't mean that it doesn't work. It means we haven't done the studies to prove it, and any clinician who treats Meniere's sees patients who improve. And it's kind of statistically impossible that all of this is just placebo effect if you follow patients long enough. So there's no evidence for the most basic of our interventions. And one other gap that we need to close is what is the outcome measure we need to use to follow to follow treatment success for future trials. More recently, with the advent of the migraine overlap and the correlation with Meniere's disease, it's kind of an eye-opener for a lot of clinicians about how prevalent migraine is in this crowd, even though it's been reported since 1861. And that seminal article from the Berlin Otologic Group showed that Meniere's attacks can be accompanied by at least one migrainous symptom in almost half of the cases. So the guidelines issued by the American Academy Committee was to assess for vestibular migraine as a recommendation. And for this crowd, it sounds evident, but I have ENT in my state that say we don't believe in the existence of vestibular migraine. You have a Meniere's disease, for example. So there's a lot of knowledge gaps that we need to bridge to understand that these are two potentially interrelated disorders, and we need to do our best to differentiate them. So it's unlikely that this is just a coincidence, and there's potentially a causal link in certain types of Meniere's disease with migraine. And some patients fit clear diagnostic criteria for one or the other or both. And also, if you follow patients long enough, some patients initially fulfill criteria for vestibular migraine, and then a few years later, if you're still following them, they can develop a hearing loss in the low frequencies, and you might need to change your diagnosis or add Meniere's to the diagnosis. And this is not surprising. When you look at the physiology of the endolymph, there's a lot of ion channels in there that are targeted by migraine medication. Most of the migraine prophylactic medications, the old school migraine medications, are sodium or calcium channel blockers, which exist in big density within the inner ear. There's also steroid receptors and beta-adrenergic receptors within the inner ear, as well as aquaporin receptors. And all of those can be found in migraine medications. And the migraine reaction, the autoinflammatory migraine reaction, can affect the endolymph theoretically. This interesting paper was published by Dr. Lopez-Escamez's group, and kind of started talking about those Meniere's subclassification that Dr. Bigelow was alluding to. And there's like 5 endophenotypes of Meniere's disease. The classic one, which fulfills the criteria that we talked about, that has absolutely no gray area with it. There's the type 2, which we call delayed high drops, following a surgery, a trauma, or those are the patients who had a sudden hearing loss, and then 20 years later they start having episodic recurrent vertigo. And there's type 3, 4, and 5, which seems to be more interrelated. The familial type, type 4, which has some sort of migraine history, not vestibular migraine, so a migraine history, migraine headaches, visual auras, satellite to the Meniere's disease diagnosis. And type 5, these are the patients who have some sort of autoimmune disorder. And more recently, the same group looked at vestibular migraine endophenotypes and identified 5 clusters, one with longer duration of vertigo attacks, one with absent migraine headaches and cochlear symptoms, and then group 3 and 4, they have cochlear symptoms during the vertigo attack or cochlear symptoms and headaches during the vertigo attack, which are almost impossible to differentiate from a probable Meniere's disease diagnosis. And only if there's an audiogram that shows the low to mid-frequency hearing loss can you say this is Meniere's disease. And the 5th group is patients who have classic migraine headaches and no cochlear symptoms during the vertigo spell. And the hypothesis is that vestibular migraine can present with peripheral symptoms, and it could affect the labyrinthine artery, causing a vasospasm of the labyrinthine artery, which can lead to otologic symptoms, or can strictly affect the brainstem, which can lead to those more central signs without otologic symptoms. And the question remains if we can differentiate the two pathologies. Are there any inflammatory biomarkers? Can we use imaging to differentiate between the two? These are some of the biggest care gaps that we have currently, and there's a lot of groups looking to solve this. We know that certain types of cytokines are more represented in Meniere's disease, like interleukin-1 beta is highly prevalent. The group from Dr. Vambutas has looked at immune-mediated inner ear disease, which is almost sometimes, bilateral Meniere's disease can be difficult to differentiate from autoimmune inner ear disease with vestibular symptoms, and they found higher levels of TNF-alpha and interleukin-1. Our group published recently on a pilot study looking at cytokines differences between vestibular migraine and Meniere's disease, definite Meniere's disease, and we found higher levels of TNF-alpha and interferon gamma, and lower levels of ENA78, which is an eosinophilic marker. And this is at the resting state before any antigen stimulation. So there's a lot of progress to be made in this field so that we can understand what type of response, and that if we solve this, not only can we create better diagnostic tools and biomarkers, but potentially therapeutic targets. So in clinic, when we have migraine or vestibular migraine, in addition to Meniere's disease, it's important to treat both. I would never proceed with any ablative procedure if there's any migraine feature that has not been treated or addressed. Many patients find that their attacks of Meniere's disease can be triggered by the same foods or dietary elements that trigger a migraine, so I put everybody on both a migraine diet and a low-salt diet. Also, for some patients, sometimes the vertigo settles down, but they still continue to have otologic symptoms, whether it's fluctuating tinnitus, oral fullness, hypercusis, and these could be related to a type of neuropathy and can be due to a migraine response. So I would always consider migraine treatment for patients who have no more vertigo but continued otologic symptoms. So the last part of what I want to talk about is what are we doing wrong from a clinical trial standpoint, and why haven't we been able to identify yet any successful treatment with all the trials that have been done in the past decade. We looked at 15 studies with various interventions, whether it's beta-histine, the SAC shunt surgery, the intratympanic dexamethasone injections, and we found that there's a lot of inconsistent reporting of the outcomes. There's a non-standardized reporting of outcomes, and we found a high level of placebo effect. 52% of patients treated with the placebo had a reduction in vertigo symptoms for as long as 2 years. There was less prevalent effect on the hearing outcomes. And it's kind of self-evident that the placebo effect affects mostly the subjective outcome measures. Placebo effect is more prevalent at short-term vertigo control. Whether it's due to disease remission or the fluctuating nature of the disease remains to be seen. And other factors that can affect the placebo effect include patient characteristics, physician-patient relationship, and the treatment expectations. We did our own study, a single-center randomized double-blind study looking at venlafaxine, which is a serotonin norepinephrine reuptake inhibitor, to look at whether it can work on Meniere's disease using its ability to work on the aquaporin receptors. That was the theoretical concept behind it. This project was supported by the American Hearing Research Foundation and Cures Within Reach Foundation. And we started that study. We recruited our first patient 2 weeks before COVID hit. So that study was supposed to take 1.5 years. It took 3.5 years to complete. But what is also interesting, we had a lot of lessons were learned from this study. First of all, our power analysis for the sample size was based on a routine 20% placebo effect you see in most literature. If we had done it on a 50% placebo effect that we acknowledged with that systematic review in 2023, we would have had to at least double the sample size. We screened over the 2.5 years of recruitment 182 subjects for eligibility and entered them into a 4-week eligibility window where they had to do a low-salt diet and track their symptoms and had to have at least 2 episodes before getting into the trial. Some of the patients improved on the low-salt diet. Once you had them do a good low-salt diet, identify their triggers, they were able to manage their symptoms and they didn't feel the need, even though these were patients that were struggling by the time they got to the clinic. Some subjects did not want to consider the trial because they did not want to risk getting the placebo, even though it was a crossover design. And I'm glad we have a patient representative on the panel, and because we have to always encourage those patients to consider, since we don't have a cure or a standard treatment that works, and everything is basically 50-50. In a way, even what we do in clinic. I tell patients, this is a treatment that may work on you, it's 50-50, and going into a trial, if it's available, you have a 50-50 chance of getting the placebo versus getting the treatment. The duration of the study was 5.5 months, trying to account for some of the fluctuating nature. And both the placebo and the venlafaxine group had improvement of outcome measures, which is the definitive vertigo days and DHI, compared to baseline, with more than 50% reduction in the number of episodes per month. Now, looking post hoc at the study, some patients are still on the medication and refuse to come off of it. We prescribed it to them off-label after the study ended. But the question that remains is, why aren't we able to find any treatment that has a good signal statistically that can be promising? And it has probably something to do with the way we're designing those clinical trials. And for Meniere's disease, we may not be able to do the classical double-blind randomized trial. First of all, we might have to identify and study separately the multiple phenotypes. A Meniere's patient with migraine can be studied in a different subgroup than Meniere's disease class 1 or delayed high drops or post-traumatic Meniere's disease. And Given that this is a relatively rare disorder, that begs the question about recruitment and accrual of subjects and the need for multi-site clinical trials. Longer follow-up, which can lead to more attrition rate, but this is also another point where we need multi-site collaboration. Standardizing the outcome measures to facilitate comparison between studies, trying to use objective measures to identify a true vertigo attack of Ménière's disease using remote recording rather than just relying on the patient saying they're dizzy, because they can be dizzy without it being a true Ménière's attack. Objective identification of fluctuating hearing loss using smartphone applications, and considering a different design than the double blind, which has been done in psychiatry and depression, the STAR-D design, where a patient selects a list of acceptable medications that we use in real clinical setting. All patients start with the same medication, and after a typical clinical follow-up, if there are side effects or no response, the patient is randomized to a second-tier medication with either complete switch or addition therapy. So an example, and I'm finishing up on my talk, of a tiered protocol for Ménière's disease. All participants could be started on a low-salt diet and a diuretic. If improvement of symptom at month 3, which we would do usually in clinic, you can continue 12-month follow-up. If the patients fail, you can randomize subject to step 2. You can switch to beta-histine with escalating titration or add beta-histine with escalation titration versus going to steroids or migraine preventive treatments. The STAR-D design for depression was open label and non-placebo controlled. We can even consider designs that include a placebo-controlled arm. So in rare non-fatal diseases with no cure, clinical trial interventions are considered an equipoise compared to standard of care treatment. And it is ethical for the clinician to actively encourage patients to participate in the trial. And I explained to them that what we currently do is a 50-50 chance anyway. Once we design trials better, stratify patients better, improve funding, which sounds tone deaf by the day, when I did the trial, nothing was happening from an NIH standpoint. Standardize outcome measures, we may have a shot at solving this. Please consider applying your grants to the ANS VeDA grant that looks at topics aimed at improving clinical outcomes for patients with vestibular disorders. The deadline is coming up soon. Consider sending your patients to those registry studies, and I'm happy to answer any questions.
Thank you. Any questions for Dr. Rizk?
So that was a great talk. One of my biggest issues with a lot of these patients is compliance. So, for instance, dietary compliance, they tell us, oh, I think I'm following a low-salt diet, but we really don't have a way of monitoring. What do you do in your clinic, and how do you really enforce that they're actually doing what they're supposed to be doing?
This is a tough one there are some patients from the get-go, you know they're going to do well because they are very well regimented, disciplined. And I encourage them to use the apps. MyFitnessPal is one that I've actively encouraged patients to download. Even the non-paying feature has a way to track sodium and has barcode scanning. But I think we actually need to do a study, a simple study, starting with this, doing a study looking at, is low-salt diet actually necessary? And what is the threshold? Because patients often ask us, what target should I get to? And it's kind of human nature. If you don't have a target to aim for, from a salt-wise, they're not going to know what they're going to do, and they're not going to track them, very well. So I don't have a real way to do it other than rely on their own characteristics. I encourage the use of the apps, though. Yes.
You mentioned fluctuating hearing loss, that we should monitor that, but what about detecting nystagmus during attacks? I think this can be very useful also in terms of having the right diagnosis that the patients actually have nystagmus during attacks.
Yes, I think we should rely on objective recording so in a clinical trial design, we should rely on recording of the episodes if we can. Everybody has an iPhone these days, to look at the nystagmus. And I don't know, probably many of you I've had patients have a Ménière's attack in my clinic as I was talking to them, and it goes from 0 to 100, and it's pretty impressive and unmistakable.
But it rarely happens that
it
have
rarely
during-
happens. Yeah, but if we're designing trials, I think we should do objective recording if we want to increase our, our chances of success.
Thank you for your wonderful talk. I have a question on, are you aware of if there are any wearable devices that can provide a more objective evaluation of the episode of the vertigo?
I know that there's many companies looking at providing a wearable device, but I mean, usually, with the iPhone, if they are able to, I mean, Heather can speak to this. The vertigo attacks can be very debilitating, but sometimes if you have somebody that can record the eye movements, that can work. But there's a lot of companies working on something that can be placed around the head that can record the eye movements.
Dr. Rizk, a question about some of the patients I see have this sense that they can't get their hearing aids correct, that they feel like they kind of go through a lot of different trials of hearing aids. Is that something that you find goes into symptom management? Like if they feel like they really have the right ones, they do a lot better, or how does that play in?
I mean, diplocusis happens with Meniere's disease to the fact that it's a cochlear pathology, and they can feel like they have this distortion of the sound. What I tell patients is, sometimes I encourage them actively, especially if they have a severe hearing loss that fluctuates into a better range, to get those amp cross devices that can be fitted into a regular hearing aid versus a cross hearing aid at times. Audiologists don't like them much, but for the Meniere's patients, they work, and they can allow them to switch between modes depending on how they're doing on a specific day.
Just following on when you were talking about frenzel glasses with iPhones, at the Barani last year, there are a number of companies that are doing that. They're very cheap. You can find them online. There's been 6 or 7 different companies that have used the technology of the iPhone. They put on a little kind of a microscope to the end to make sure they can focus on the eye. Mm-hmm. And there are some people that have some custom 3D printed machines that then just fit it to the actual patient. And so online there are quite a few people that are doing that.
And they're available for the US market, you're saying?
I think so, because I've bought them for people when I visited these conferences, and there are some people that will ship all over the world, so they are available.
Thank you. Thanks.
Well, thank you, Dr. Rizk. That was a very excellent talk. Really appreciate your insights, especially about clinical trial design. To talk to us a little bit more about migraine and Meniere's disease, we have Dr. Jeff Sharon.
Thanks. It's a pleasure to be here. Can everyone hear me okay? Yeah? There's kind of like an echo up here, and I couldn't tell if you all can hear. Okay. So I'll dive in. Habib, thanks. That was a perfect segue for what I wanted to talk about in terms of vestibular migraine and migraine in general and Meniere's disease. I do have some disclosures. I'll talk about some data from an investigator-initiated study that was paid for by Eli Lilly. And then I am a paid employee of Spiral Therapeutics, which does Meniere's research. So migraine is shockingly common. You all know someone in your life who has migraine. It affects 10 to 15% of people worldwide, which is an astonishing number. 4% of the population has chronic migraine. Migraine is the most common cause of disability for those in their working years. The scale of migraine cannot be underappreciated or underestimated. What isn't discussed as much is that the earliest migraine manifestation is not a headache. And we all think of migraine as synonymous with a bad headache, but when a 2-year-old suffers from migraine, they get vertigo. And migraine and vertigo are therefore biologically linked, likely in profound ways. And some of the talk today will be, I'm not going to have definitive answers, I'm going to have some thoughts in terms of ways to think about how they could be related and whether or not it is worthwhile to explore the link between migraine and basically I'll say every other ear disease, but for today's talk we'll focus on Meniere's disease. And there you see some fancy animations. So migraine and other vestibular diseases, it's so bizarre to me that it's connected, but it is. When you start looking at the connections between migraine and every other disease I, as a neurologist, treat, you find connections. Dr. Rizk mentioned that more than half of patients with Meniere's disease meet criteria for migraine. Migraine's associated with a twofold increased risk of BPPV, and when we repeated that study at UCSF, we found that it was associated with earlier in life BPPV. So you would get BPPV 5 years earlier if you had a migraine history than if you didn't. And 50% of patients with idiopathic bilateral vestibular loss have a history of migraine. So go figure. So clearly there's something going on here. I cannot believe this is all coincidence. I guess I do believe that migraine affects the inner ear in ways that we don't understand, but ways that we need to understand to advance the field. This was a paper we came up with a number of years ago, and we tried to map out the diagnostic landscape of vestibular disorders, and what you see is a lot of overlapping circles. This is not the case with some other things I treat. You know, when I see a brain tumor on an MRI, if we diagnose it as a vestibular schwannoma, it is therefore not a meningioma. Those circles don't overlap. But here, when you look at vestibular disorders, and you could see Meniere's in particular, there's large overlaps with migraine, with BPPV, with bilateral vestibular loss. So we're seeing a complex web of interrelationships between vestibular entities, and we have to accept that in order to properly investigate them. So I guess I'm saying I view migraine as the elephant in the room that is basically involved with every symptom and disease that ear specialists treat. And even when it's not directly involved in pathophysiology, it still seems to be involved with outcomes and response to treatment, as is the case with superior canal dehiscence syndrome. So let's talk about CGRP. Why do we want to talk about that? Because it's a potential link, and it's something we've been studying, so I want to add it into the discussion. So what is CGRP? Calcitonin gene-related peptide. No need to remember that. We all just call it CGRP. It is a neuroinflammatory peptide that is now thought to be part of how a migraine happens. So it's found throughout the peripheral and central nervous system. It's released by the trigeminal-vascular system, and it is found and expressed, what's not as well known, in the vestibular periphery. So here I have a slide from a paper from Ann Lubke's lab in Rochester showing a mouse utricle where you see CGRP expression, and interestingly, the location would suggest an involvement with the efferent vestibular system, which is an intriguing thought. So how do we know it's related to migraine? Well, a series of experiments years ago, Lars Edvinsson and others infused CGRP into migraineurs and caused a migraine. So that's a pretty good argument that CGRP is related to migraine. Another argument is that there's now 2 large classes of medicines that block CGRP and have proven efficacy in treating migraine. Those medications are monoclonal antibodies and also GPANs. So GPANs are pills that you take, and the monoclonal antibodies are injected and usually last a month or so, and both are used to treat migraine headache. Neither one is often a cure, but they are very often a successful treatment and for many patients a game changer. Interestingly, though, CGRP, in addition to its relationships to migraine, is related to vestibular dysfunction. So Dr. Ann Lubke has shown that CGRP knockout mice have balance difficulty and lower VOR gain, and I'll show that here. So here are some experiments they did with these CGRP knockout mice, and you could see clear alterations of VOR gain not affecting the phase. So clearly some relationship between vestibular response to stimuli and CGRP, and also impaired balance. So these mice have to balance on the rotarod, and after the training trials, the CGRP knockout mice have impaired balance. So this is very intriguing to me, that CGRP appears to be connected to proper vestibular function. So we did a trial that we finished up last year called the investment trial. It was a pilot-sized trial looking at one of these CGRP blocking drugs, and that drug was galcanezumab, which is sold under the name Emgality. And this was a double-blind, randomized, placebo-controlled trial funded by Eli Lilly, but it was an investigator-initiated study from me. And we had a 1-month baseline period, 3 months of treatment with a 1-to-1 randomization between drug and placebo. And what we're showing here is the DDD count. That stands for definitive dizzy days. So every day in the trial, you got a text message. The text message said, rate your dizziness over the last 24 hours as none, mild, moderate, or severe, and moderate or above was counted as a definitive dizzy day. So the average person at the start of the trial had 18 of these definitive dizzy days, so relatively high disease burden, but that's who signs up for clinical trials. And by the third month of treatment, there was a difference between the placebo and the control group and the treatment group. So the treatment group dropped to 6.6 days, and the placebo group was 12.5 days. So nice separation between the two, but clearly either a placebo effect or a regression to the mean effect, as Habib was alluding to. The dizziness handicap inventory also had a nice separation between the two groups, with those getting treated dropping 22 points. Habib's published on the MCID for this scale, and this study just beat that. Okay, so let me lay out the argument. The argument is Meniere's disease related to migraine? So we'll go through, could it be? So number one, epidemiologically, we've talked about the fact that more than half of patients with Meniere's disease meet criteria for migraine, more than you'd expect by chance. And in a cohort of 147 patients, NEF showed that 1/4 of patients met criteria for both diagnoses. A second line of argument would be the phenotype. So 45% of Meniere's patients always experience a migraine symptom with vertigo attacks. So meaning an aura or migraine headache or photophobia, not considered to be traditionally Meniere's symptoms. There are so many shared features between the two diseases: oral fullness, episodic vertigo, the triggers, the typical triggers like allergy, stress, tinnitus, hearing loss, sensitivity to barometric pressure. Hamid Jalilian did an interesting study where he looked at the laterality of migraine headaches in those who had migraine and Meniere's disease and found that they were correlated. So if you had more left-sided headaches, your Meniere's disease, if you had both, was more likely to be on the left side. And endolymphatic eye drops can be present in vestibular in migraine, not very commonly found though. Is there a pathophysiologic link? Can we come up with a study? Well, there's an oft-quoted study from Zoltan Vass from 2004 where he looked at these blood vessels. So these blood vessels that are innervated by the trigeminal nerve, and they do go out to the inner ear. So he was looking at the SMA, or spiral medullary artery, and he was activating the trigeminal-vascular system, and he caused plasma extravasation. So that's what you're seeing in the images there. C is the control, and A and B are the treatment arms. So you can cause plasma extravasation with stimulation of the trigeminal-vascular system. So that is a plausible link between the two diseases. So I'll read what he said in this paper 20 years ago. He said, the findings suggest that stimulation of paravascular afferent nerves may result in permeability changes in the basilar and cochlear vascular bed and may contribute to the mechanisms of vertebrobasilar type headache through the release of substance P, which is another neuroinflammatory peptide similar to CGRP, and the stimulation of the TPVR1, which is the receptor, respectively. We propose that vertigo, tinnitus, and hearing deficits associated with migraine may arise from perturbations of capsaicin-sensitive trigeminal sensory ganglion neurons projecting to the cochlea. There you have it. Here's an interesting study from Yoon-Hee Cha and Bob Bigelow showing that when you had Ménière's disease and migraine, you were likely to have your Ménière's disease earlier in life. Compared to just migraine alone, you were likely to have it later in life, but they didn't see differences in hearing thresholds between those two groups. Another interesting study from the same group looked at the complex web of genetics and found a number of families that were affected by both migraine and Ménière's disease, and they color-coded. The migraine is shading in the top left, the Ménière's disease in the bottom right, and you can see here that the relationships between the two are quite complex, with some family members just having migraine, some just having Ménière's disease, some having episodic vertigo or aura, which was the other two shades, and some having all of the above. So more evidence for their interrelationships. Here's an interesting one, and nice to follow Robin's account on this. This was a historical recount by Hamid Jalalian discovering Ménière's disease and its association with migraine headaches. So he has two quotes from Ménière's himself. And I'll read the second one. I do not hesitate to regard these migraines as dependent on a lesion of the inner ear. They are accompanied by noises, by vertigo, by gradual diminution of hearing. So it's actually likely that Ménière himself thought that migraines were related to the symptoms cluster that he described. I'm running out of time, so I'm going to go quick. Does treating migraine work for Ménière's disease? This is probably the million-dollar question, right? You give a whole talk, and the answer at the end is, so what? What's the practical implication of this? I think the practical implication of this is, should we be investigating migraine drugs as a treatment for Ménière's disease? Dr. Rizk looked at effects, or actually looking for, as he noted, based on some theories with aquaporins, but did not find a difference between treatment versus placebo, and Effexor is considered a migraine treatment as well. Stefan Hegemann recently put out a report of treating 6 migraine Ménière's patients with Rimegepant, which is a GPANT, and noted Ménière symptom resolution in all of them. My personal experience with that hasn't been quite as good, but certainly we do see some effects. And then Hamid Jalalian treated Ménière's patients with nortriptamine, verapamil, or topiramate, so traditional migraine medications, and did see quality of life improvement, thereby arguing that there was some treatment effects. All right, so I'll finish with this one. This is from Miles Atkinson in 1961. And he said, the fact of the association of migraine with Ménière's disease is no new observation. Ménière's himself referred to it, but it has not received the recognition which would appear to be its due. These are the patients who are really out of luck, who continue to have migraine attacks after acquiring Ménière's attacks, one alternating with the other. Such a person lives in a very special hell. And with that, I will conclude. I put up a screenshot for those interested in this topic. Mike Teshido has a wonderful talk on the House YouTube channel, which is a great channel full of wonderful free content, and it provides a deeper dive into this topic, so I recommend that if you're interested. My conclusions are that migraine and Ménière's are likely linked, and that further study of migraine medications for Ménière's disease is warranted. Thank you all.
Thank you, Dr. Sharon. Any questions for Dr. Sharon?
Thank you for a very interesting talk. I'm so interested about the relationship between CGRP and migraine. So are there any report that what kind of stimulation activate the CGRP neuron in the vestibular organ?
The question was about the relationship between CGRP and the vestibular periphery and how you activate the CGRP receptor. Well, presumably it's the CGRP release, meaning from the trigeminal vascular system. That is the ligand that activates the receptor. I think we have to do a couple things to advance this mechanism. One of them is probably we have to show that the CGRP receptor is expressed in human tissue. The slides I showed are animal tissue. And then we need to better understand the effects of CGRP on the inner ear. Thank you.
Thank you.
I remember Amgen and Novartis did a large-scale CGRP antagonist trial. I don't know if among those patients, people looked at whether the migraine patient has, Meniere's disease and whether there are actually therapeutic effect in those patients. You mentioned sort of like a 40-50% migraine patient actually have Meniere's disease, right?
The other way around.
Oh, the other way around.
Yeah.
But there is a correlation, so it would be interesting to look at those subpopulation with Meniere's and see if that drug really in those large-scale trial, it's actually the trial is done, right?
Yes. I really like your question because I had the exact same thought. So I have asked, when I was trying to get money to do this vestibular migraine trial, my original thought is let me just approach the drug companies and ask them for their clinical trial data from their pivotal trials and see if they gathered data on dizziness as an outcome measure, and then I could save myself a couple years and figure out, do their drugs work for at least vestibular migraine? I don't know that they quantified people enough to know whether or not they had Meniere's disease. And they were not collecting that data. There's an issue with just how the neurology world views the relationship of vertigo and migraine. And so it was reported in some trials as an adverse event if someone developed dizziness or vertigo, but in none of the trials was it collected as an outcome measure. So I think it was a miss on the part of the people who did these large trials to get that sort of data.
Okay, thank you.
Thank you.
All right. Well, thank you very much, Dr. Sharon. So we've heard a lot so far about clinical trials using drugs and their effects. We're going to switch gears a little bit now, and Dr. Amy Juliano is going to speak to us about imaging and MRIs in Meniere's disease.
Thank you so much, Dr. Thibodeau. And good afternoon, everyone. I want to thank especially Dr. Divya Chari and the organizing committee for the invitation to speak. and it's great to be here among this company. So I am a radiologist, and I'm a head and neck radiologist practicing at Mass Pioneer, and my special interest is in temporal bone imaging. So I will speak a little bit today about imaging in the context of Ménière's disease, and I'll focus on the inner ear and, of course, endolymphatic hydrops. So here's the outline of my talk. I will talk about imaging anatomy. We'll talk about Ménière disease and hydrops, a bit about evolution and MRI techniques, and then what do we talk about in radiology reports when we interpret a scan of a patient with Ménière disease. First, a bit about inner ear imaging anatomy. So here's the bony labyrinth. I'm sure here we're all familiar with this. Complex structure. And for radiologists, when we do cross-sectional imaging interpretation, we look at slices. So we slice this up to contiguous sections along the body part. So here's the CT scan. CT, basically, the theory is like X-rays. How much does the substance in the body block the oncoming X-ray photons? So it's all about the substance density. The denser something is, the more photons it blocks, it looks a certain way. When something is very not dense, it does not block a lot of photons, and the substance looks a different way. So here we see bone, very dense, blocks a lot of the oncoming X-rays. It looks white, and we call that dense. Air, it's very not dense, so that looks black. So this is a CT of a left temporal bone. So on imaging, left is right, right is left. And so here we can see the cochlea, bit of the vestibule. Now we scroll up to a next slice. We see a bit still of the basal turn of the cochlea. Now we see the vestibule. And then the next slice, we see semicircular canal. That's CT. MRI works differently, and that's all about particle physics. How does a substance, physical particles, act, their spin, inside a magnetic field? So it has nothing to do with density, but it has to do with physical properties. We do different pulse sequences, so we accentuate different parts, and substances look different. So this is a T1 weighted MRI image. And you'll see here the back of the head is towards the back. The tip of the nose is in front. The patient is lying down. We can see the pinna on either side. So on a T1 weighted sequence, fluid is dark. So we see the CSF here, that's dark. A bit of the cochlea. Fat is bright. See the subcutaneous fat. And if we give intravenous contrast, the contrast is bright. So wherever contrast gets to along the bloodstream, like to a tumor, we can see it lights up. For example, here is actually a little glomus tympanicum paraganglioma. So that's a T1 weighted sequence. A T2 weighted sequence looks a bit like this, but this is not any old regular T2. This is a heavily T2 weighted MR sequence. And on this, fluid is super bright. So you can see all the fluid in the cochlea, the CSF, super bright. Everything else is dark. So you really accentuate the appearance of fluid. And if we zoom in, we can see here now, fluid in the cochlea, fluid in the vestibule, a bit in the semicircular canals, outlining the cochlear nerve. We can see the medialis, dark. Interscalar septum, dark. So that's MRI. Now, if we open up the bony labyrinth, it's not a solid chunk of bone. It's not hollow and empty. It is sort of hollow, but there's another maze inside this bony maze. And inside is this maze that's lined with a membranous wall. And that is the membranous labyrinth. So here's a diagram, courtesy of Elsevier. And you'll see here in blue is the fluid inside the membranous labyrinth. Between the bony labyrinth and the membranous labyrinth is a different fluid. That's the white stuff, that's perilymph. And that's between the bony and the membranous labyrinth. We can talk about the different parts of this membranous labyrinth. There's the utricle, here is the saccule, and here is the cochlear duct going around inside the cochlea. Now, how big are these structures? So let's look at a histologic slide. Here's the cochlea, and look at the blue. That's the endolymph. That's tiny. That's the cochlear duct. And normally, the majority of the fluid inside a cochlea is perilymph. Very little bit is endolymph. Let's look at more. So here again, we have the cochlea. That's the internal auditory canal. Here's the vestibule. In here, we see saccule, utricle, the blue blobs, right? Endolymph, blue. Tiny. The majority is white, and the majority is perilymph. That's how it's usually, normally. Now, what about in Ménière's? In Ménière's disease, there is hydrops. So these blue parts with the endolymph are big. So now we can say, all right, that's big, that's hydrops. Now we're not saying Ménière's necessarily causes hydrops or is the only thing that leads to hydrops. And we're not saying that hydrops causes Ménière, but we're saying at least at this point in early 2025, we can say in a Ménière's disease patient, we can see hydrops. And at the very least, it's an epiphenomenon. It's something that happens in Ménière. Aha. So for imagers, the question is, can we see the endolymph and distinguish it from perilymph? Because if we can, now we can diagnose hydrops. We can see it. And if a Ménière patient comes for scan, or there's high clinical suspicion of Ménière, and on imaging, I say, well, I see hydrops. That's going to help to confirm the diagnosis. So can we see the endolymph as distinct from the perilymph? Let's take a look. Here's the CT. Remember, bone is white, air is black, everything in between, muscle, fluid, fat, different gradations of gray, but not enough for us to tell between different types of fluid inside. What about MRI, the heavily T2-weighted sequence where we see fluid? No. All the fluid is bright. We cannot tell between endolymph and perilymph. It's all the same, super bright. So how are we going to do this? Well, it's been discovered. Remember I talked about how the intravenous contrast looks bright on T1. Well, it turns out if you wait long enough, the contrast permeates from the bloodstream into the perilymph, but not into the endolymph. So if you wait long enough and you do a delayed post-contrast scan, we'll find the perilymph now lights up, but not the endolymph. So now we can distinguish between those two, and now we can see hydrops. So here's a patient with a big cochlear duct, a big saccule, a big utricle. That's endolymphatic hydrops. And we can more specifically say cochlear hydrops, saccular hydrops, utricular hydrops, or as a whole, vestibular hydrops, but we can now see it. And that is huge, because for the first time now, we have tangible, visible, objective signs of hydrops in the setting of Ménière. Here's a patient, left ear, that's to the right, and right ear over here. You can see the difference between the two. Big cochlear duct, big saccule, big utricle. That's hydrops in the right ear, but not the left. So how did this come about? The first time this was discovered was back in 2005. A group, Zhu et al., they were authors from Finland, from Sweden, and from China. They collaborated and they looked at guinea pigs, and they also scanned humans. They introduced contrast agent directly onto the round window membrane. They also inject it through the vein. And they found that if you wait, the perilymph lights up with contrast. So this was the beginning of the era of imaging of hydrops. 2 years later, Nakashima, Naganawa in Japan, a big group that did a lot of work in Ménière imaging, they started doing this clinically in humans. There's a sequence, you may have heard of this, 3D FLAIR, fluid attenuation inversion recovery. It's feasible to visualize endolymphatic hydrops. And in the beginning, they inject it through the drum. And contrast permeate through the round window membrane. You can see as bright perilymph, and the little dark areas are endolymph. But you only get benefit of one ear, otherwise you have to inject both drums, and you have to wait a long while. And in subsequent years, in the last 2 decades, lots of research going on. This is just a sampling of the papers. There's so many more, just showing the evolution. went from intratympanic injection to intravenous injection, different imaging techniques, but these all tend to be very long scans. Good, so now we can see this. And what am I gonna say on an imaging report? Well, first of all, of course, I'm looking at the size of the cochlear duct, saccule, utricle. And in particular, this is the saccule that's big on the right side. Saccular hydrops correlates with Ménière symptoms. The other thing that's been discovered, and this is not specific to Ménière, but if the perilymph takes up a lot of gadolinium, there's something wonky with the blood perilymph barrier, and that is a sign of sensory nerve hearing loss. So the greater the degree of perilymph enhancement, there is sensory nerve hearing loss, and that's another parameter we can talk about. So when I'm reading a report, imaging, what I'm gonna say in my report is the size of all the different endolymphatic structures and the degree of enhancement. Great, that's the story of imaging, right? No, we have gone beyond that now. What else can we talk about? Well, it turns out that there has been discovery as to the mechanism of Ménière disease, and we'll hear more about this later on. So it turns out that not all Ménière patients are the same. There's something going on with the endolymphatic duct and sac. Something is wrong with it. But what's wrong with it? What's been discovered is that some patients have an endolymphatic sac that never developed properly. And some patients had it developed properly, but then the lining degenerated. So these are the two endotype phenotypes of Ménière disease, the hypoplastic form and the degenerative form, the two different endotype phenotypes. So here's a landmark paper by Bechinger et al., and David is here in the audience, along with Andreas Eckhard. And they, in this landmark paper, described the two different endolymphatic sac pathologies within Ménière patient population, the hypoplastic ones and the degenerative ones. Now, can I say this in my radiology report? Actually, no, because I cannot see the endolymphatic sac. Unless it's huge, then sometimes I can diagnose that. But when it's small or normal, I can't see it. So what use is it for me as a radiologist? Well, it turns out that in this paper, there's a second big point. And the second big point is that the vestibular aqueduct can give you information. The vestibular aqueduct houses the endolymphatic duct and sac. And it turns out that the morphology of the vestibular aqueduct tells you something about the situation of the endolymphatic sac inside. And it turns out the vestibular aqueduct looks a certain way when the endolymphatic sac never formed. And the vestibular aqueduct looks a different way when the endolymphatic sac and duct are fully formed. So now, on imaging, I can see the vestibular aqueduct for the most part, especially on CT. And if I look at it, I can say, I think the endolymphatic sac never developed or developed properly, but if the patient has Ménière's, the lining degenerated. So let's take a look at this. We're gonna tell the Ménière disease endotype on imaging. So this is a right temporal bone, and I'm scrolling up and down, and so you can see here the pinna, the patient is lying down, back of the head towards the back. So I'm gonna scroll. So here you see the lateral semicircular canal, here you see the vestibule, and here comes the vestibular aqueduct. It comes out, it bends, and here's the back part that goes towards the posterior fossa. And that's how it usually looks. The main part of the vestibular aqueduct is kind of sideways, kind of horizontal. That's how it normally looks. So I want to show this cadaveric specimen that we scanned of a temporal bone. This is the right temporal bone because it shows so beautifully the whole course of the vestibular aqueduct. You see this front part that's going to go towards the vestibule. Now that always comes out of the vestibule at a fixed angle, and that was shown by David and Andreas and their team. It always comes out at the same angle, but not the back part. This, in a normal adult, looks like a hockey stick. The part that hits the puck comes out of the vestibule, always at a fixed angle. The handle of the hockey stick is the part that goes towards the back. This angle between the part that hits the puck and the part that your hands hold onto, has been coined in their landmark paper in 2019 as the ATVA, angular trajectory of the vestibular aqueduct. And it turns out that in fetuses, this part of the handle is actually kind of short and straight. It doesn't really bend that much. So the ATVA is very close to 180 degrees. And in fact, they found over 140 degrees in fetuses. In a normal adult, it bends, so it's closer to 90 degrees. In fact, they found less than 120 degrees. So now we know if the angle is a certain way, well, it tells us about the endolymphatic sac. In a fetus, it's not yet completely developed. So if it's a long, short, straight vestibular aqueduct with a large angle, that implies a hypoplastic or underdeveloped endolymphatic sac. Whereas in a grown-up, fully developed. So if we see the normal angle, that's a fully developed endolymphatic sac. But now if you tell me, actually these are both grown-ups with Ménière disease, well then, I'm gonna say, you know what? This one was never developed properly. That's going to be the hypoplastic endotype of Ménière disease. And if you tell me this other patient on the right is also a Ménière patient, well, I'm gonna say, yeah, they had it formed properly, but the lining degenerated. So now I can tell the different endotype phenotype on imaging. And that has prognostic implications. So we're using ATVA as a surrogate to tell the status of the endolymphatic sac and endotyping the patient into the subset of Ménière disease. But it turns out it's not so easy to see the vestibular aqueduct. They're often very small on imaging, and on MR, really hard to see. But it turns out that the bone thickness is correlated, and this has also been published by David and Andreas' team. So if the endolymphatic sac never formed properly, it turns out the entire temporal bone kind of is a bit underdeveloped. Mastoid may not be pneumatized so much, and the bone behind the semicircular canals tend to be thin. So now it's tough to measure the angle, but it's not hard to see the bone thickness. It's thin here, hypoplastic endotype. It's thick here, degenerative endotype. So now we can use the retrolabyrinthine bone thickness as a surrogate of the ATVA. So by looking at the bone thickness, I have a good idea if the patient belongs to the hypoplastic endotype or the degenerative endotype. The story is a little bit more complicated than that, but look at this purple box here. Anytime it's a fetal ATVA, there is no thick bone. So if I see someone with thick bone, I have basically ruled out the hypoplastic endotype. So we published this last fall, showing that we can add that to our radiology report, which has prognostic implications for the patient. So when I report, what do I talk about? The size of the endolymphatic structures, cochlear, saccule, utricle. I talk about the degree of perilymph enhancement, because it matches sensory nerve hearing loss. And if I can, I talk about the ATVA, but better seen on CT, or the retrolabyrinthine bone thickness, which you can see on CT or MRI. So in summary, MRI is now allowing us to see high drops. That's a tangible, visible finding, and it's changing the landscape. We have additional anatomic features to help us subtype the Ménière disease, so we can give some prognostic implications for the patient, which we'll hear about later this afternoon. What's happening in the future? Well, we can improve imaging techniques, faster scan time, higher spatial resolution. Radiomics is a big deal, things that cannot be seen by the naked eye. Maybe AI can help us figure out differences in texture. And anything else is what I think the beauty of meetings like this is for, where researchers gather together and we find the next horizon. So Andrea shared with me the slide that I really wanted to show you. I'm really honored to be a part of our group that we meet together every week to talk about what we can do for Ménière disease and Ménière disease patients. I thank you so much.
All right, I think we have time for one or two questions for Dr. Juliano, if anybody in the audience has a question.
That was fascinating. Does every Ménière's patient now get a temporal bone CT at your institution?
I would like that to be the case. I think they do get the MRI with the high drops protocol, and once in a while they do, in addition, get the CT so we can help better with the endotyping. But ever since we've been able to show the retrolabyrinthine bone thickness is a good surrogate, we can kind of get a good idea, and that's a routine part of our radiology report.
That was a really great talk. I'm wondering if you could comment a little bit about the logistics of scanning MRI at just after contrast and 3 to 4 hours later, and how you were able to incorporate that into your routine clinical care.
Yeah, so when we first started doing this, we would have the patient get scanned, get the intravenous contrast, get a couple more images, and then they can go to their clinic visit in otology, they can go shopping, they can go to the cafeteria, then they come back 4 hours later and we do that scan. Lately, we've stopped doing the initial part. So when they come, they just get the injection and they leave, kind of like a nuclear medicine scan almost. Then when they come back, all the imaging is done at a delayed post-contrast. So that does require clinicians to figure out that they don't actually need the IAC protocol. They're just really here to look at the high drops. But in fact, we do sequences like the heavily T2-weighted sequence. So we can rule out vestibular schwannoma, we can rule out some other things.
How specific is the finding of endolymphatic high drops for Meniere's disease? For instance, if we, let's say, scan a lot of patients with just asymmetric hearing loss, how many of them would have endolymphatic high drops?
I think that would be hard to answer because we don't get the requests for patients that they don't really have a high suspicion for Ménière. I would say that I always read my scans without looking at the clinical history because I don't want to be biased. So I never pull up the chart to see which ear, whether, is this just a rule out? Are they, do they think it's actually a vestibular migraine? I never look. And I would say for the most part, when I look at it and then I look up the chart, it jives. So it does seem to be very much matching the clinical impression. Whether healthy patients could sometimes have it, it's harder to say because we don't really have many patients who don't have high suspicions for Ménière come for the scan. I would say the contralateral ear, though, might be a good sign of it, unless that's the herald of the beginning. And that often would be negative. We don't see bilateral, for example, all the time. It's more often, it's asymmetric, it may be unilateral. So I don't doubt that it's valid.
I see one question in the back, and then we'll move on after that.
Yeah, continuing from that same line of thought, quite a while ago, Steve Rausch showed abnormal VEMPs contralateral to Meniere's ears. And so my question is, how often do you see eye drops in the contralateral ear in people with unilateral Meniere's disease?
So I would say saccular eye drops, not common at all. Cochlear duct prominence, we often see it even in patients who are not quite symptomatic. And I think that the cochlear duct can be a bit prominent without there being symptoms. And I don't know if that heralds the beginning of maybe the rest of it having some enlargement. But the saccular eye drops, no, I would say.
That's puzzling because you would expect for the VEMP abnormalities to be present that they have saccular eye drops.
Yeah, I do think that it would be a bit asymmetric, but then again, if I see that the chart does say there are symptoms, there's clinical testing on that side, that actually to me might be a positive that would jive with the read. So, yeah.
All right, thank you, Dr. Juliano. So that concludes the presentations we have in this clinical portion. We're going to have a moderated panel discussion now. So the speakers who are not on the panel, thank you very much for your presentations. You're welcome to join the audience, and we'll bring up the moderator and the rest of the panel. Yeah.
Well, good afternoon, everyone. So this is a very fairly short panel discussion about patients. I'm John Oghalai. I'm from USC, and then we've got Habib and Jeff, who spoke earlier, and then we're adding in Dr. Bill Slatterly from House Ear Institute. And this is just going to be some practical patient scenarios, and I'm just going to kind of pose questions to the panel members and see, how they would work up the patient, how would they treat the patient, what are their thoughts. So here's our first patient. Patient number 1, a 32-year-old female. She owns a store. She's had fluctuating right ear fullness and hearing loss for 6 months. She's had 3 episodes of severe vertigo and kind of has some mild dizziness the rest of the time. And I've got her audiogram here and word recognition scores. I don't know, Jeff, do you want to just maybe start off, maybe interpret the audiogram and tell me what you're thinking?
Sure. So your audiogram shows normal hearing thresholds in your left ear, and then the right ear has a low frequency sensorineural hearing loss. This patient's 32 and has some concerning symptoms for Meniere's disease. I always try to distinguish if they're having any of the characteristic triad of Meniere symptoms at the time of the vertigo. So is there oral fullness, is there tinnitus, and is there hearing loss with the vertigo? Because I feel like that strengthens the connection. And then we do, my history, I exposed all that in my talk, so I'm always curious if there's a migraine history, if there's any other otologic conditions, if there's any other medical problems as well, to try to further characterize what's going on.
Yeah, and none of these are trick questions. You don't have to worry. Sometimes at our medical conference, there'll be like a surprise tumor will pop up or something. We're not doing that here. Okay. Oh, boy. Habib, what would be your next step in working up this patient?
This is a fairly classical patient where I wouldn't get an MRI from the get-go. It looks like an asymmetric low-frequency hearing loss. So I would straight ahead and talk to the patient about Meniere's, explain that this is my highest suspicion. I'll put them on a low-salt diet and a migraine diet and give them medication to manage the severe vertigo attack. Usually I give them a first aid kit, promethazine and Valium to have on hand, and bring them back after a few weeks with a diary that, to see what is the number of their episodes and discuss next steps depending on how severe their disease is. If the hearing loss hasn't, that audiogram, for example, was obtained from they usually fluctuate and then come back to baseline within 24, 48 hours. I don't do anything. But if their hearing doesn't recover to baseline more than 48 hours after fluctuation, I suggest steroids as well.
Do you do oral steroids or intertympanic or both or either?
I would start with oral steroids, and when they return, if I repeat the hearing test and they're still low or they're having multiple episodes of vertigo, more than one a week usually, I consider IT steroids.
Okay. But for this patient on initial presentation, it would be a diet, low salt diet and a diuretic.
And diuretic, if they're not on it, I would discuss it with them. Mostly the diet I would start with.
Mostly the diet. Okay, very good. Bill, would you have any other thoughts on this patient or do anything?
So a couple things. One is I always like to characterize, are they what I call classic Meniere's disease? And the way I define that is, vertigo episode 4 to 8 hours. The symptoms occur at the same time of the vertigo episode. It's resolved by the next day, and then they're back to normal. That's I call classic, because then you get this what I call atypical Meniere's disease. And I go back to, like George Gates used to say, Meniere's disease should be called Meniere's syndrome, because as was pointed out, you talked about 5 different categories. There's probably more than 5 that we just don't know yet. And so, that's why I like to characterize is this classic or not. Anybody that has unilateral symptoms, I always get an MRI scan. It's just part of our standard evaluation. Patients who come in with vertigo spells, I will do the similar migraine diet, low salt diet, but I also will put them on diuretics because I figure I really want to know if this helps stop the vertigo spells. They've had 3 episodes over the last 6 months. We'll start it for a month, reevaluate 4 to 6 weeks later. If they have no spells, I'll continue the diuretics for 4 months total, and then I'll have them come off at that point in time.
Very good. Any other comments on this patient?
Back to the history, we focused on a migraine and history, but the other thing we kind of touched on was allergy. And at least in our practice, Jennifer Dearbury, had a lot of Meniere's patients and found that the incidence of allergies, and we'll touch on that with autoimmune as well. Is that immune? Is it autoimmune? But there's a significant number of these patients who have allergies, and if you get the allergies under control, sometimes just allergy management will control their Meniere's disease. So is that immune-mediated Meniere's disease? Is it a different variant? Again, these are some of the things we still don't know.
Mm-hmm. What about the role of stress, other illness on this kind of thing? Does that play a role? Have any of you seen that impact this kind of a patient situation?
Many patients report that stressful events or poor sleep can also trigger an attack. We also notice weather changes in some patients. Barometric pressure changes seem to be very triggering events, mostly in the vestibular migraine crowd, but also in my Meniere's patients with migraine features.
Mm-hmm. And just to comment, since you brought that up, it just reminds me, Jennifer Dearbury would always talk about the barometric pressure means that there's fungal allergies that plays a role. I don't know if that's true or not.
I know so in South Carolina, there's fungus year round. But I also looked it up once, and a fun fact, Charleston has the highest variability of barometric pressure in the entire continental U.S. Whenever there's hurricane season in Charleston, my Meniere's patients are the only ones who don't evacuate. They're in my clinic to get a steroid shot or something.
Oh, wow.
Mm. Yeah, the barometric pressure I'm so curious about because how is it sensed? Some long haul birds who migrate around the whole globe have an organ in their inner ear called the paratympanic organ that's directly can sense barometric pressure, and that's how they stay at a constant altitude. And it's unclear to me. Maybe someone knows how a human would sense barometric pressure changes. But we do hear that frequently as a complaint.
Mm-hmm. Currently doing a study with Amir Karadmand at Johns Hopkins, and we're recording mostly vestibular migraine patients, but in my center we're also enrolling Meniere's patients, and we're tracking through an app their geographical location and then mapping it to barometric pressure. So we don't even know if it's a true correlation yet. We're trying to figure out if it's barometric pressure, temperature, humidity, or pollen count, or all of the above. So I guess we're going to know in the next few years.
Right, and I think there was a similar study with an NHS in the UK that found some weak correlations. I'll also add, I guess, regarding stress, not with Meniere's disease, but with vestibular migraine. I'm in San Francisco, so we did a very San Francisco study, we did a study of mindfulness-based stress reduction as a treatment for vestibular migraine, and it actually worked pretty well, and a lot of people seem to convert the moderate severity vertigo into a mild severity vertigo. So I think stress management is important with vestibular disease.
Mm-hmm. Okay, patient 2. This is a 54-year-old male attorney. He has fluctuating ear fullness on both ears and hearing loss for about 5 years. He sometimes now gets episodes of severe vertigo. It used to be worse. It's not as bad now. But he's dizzy most of the time. And maybe we'll go in reverse order. Bill, do you want to kick off, interpret the audiogram, and give your initial impressions?
Sure. So this audiogram demonstrates a low-frequency sensory neural hearing loss in the right ear that comes up into the normal mid-frequency range and then drops off in the high frequencies. In the left ear, we also have a low-frequency loss, not quite as bad, that peaks at 2,000 hertz and then drops off in the high frequencies. Your classic Meniere's disease is low frequency that kind of peaks at 2,000 and then drops off. So both of these would be considered kind of classic audiograms with a low frequency loss. The second part that's important is to look at the discrimination. So the discrimination in the right ear is 76%, which means that when we ask them to repeat the words back, they only got 76% of the words correctly. The way I like to describe this to patients is talking about the old analog radio, where you have a volume knob and you have a tuning knob. And the problem that you have in Meniere's disease is that you don't need just volume, but you also need tuning that has, because many times there was a question earlier about hearing aids in Meniere's disease patients. And one of the things that I find that many of these, and I think we kind of alluded to it, but Meniere's disease patients many times will have poor discrimination, which means you put more sound into their ear, they still don't understand more, it just gets more sound. It's just like the old radio, when it's not tuned properly, turn the volume up as much as you want, but it's still not clear. And I use that analogy because it tends to, people kind of resonate with it if they're over, 30 years old and know what an old two-tone, knob radio is. But it's also helpful for the patients to describe to their friends and family members of why sometimes a hearing aid will not work in that Meniere's disease ear, because no matter what you turn up, it's just so difficult for them to understand.
Okay. Habib, what's your workup for this?
I also, it's in a very classical case, I usually shy away from an MRI unless they're not responding to treatment, which, there's no urgency in getting it in this case, in my opinion. The fact that they're dizzy most of the time, I want to do a vestibular workup clinical exam, make sure that they don't have any vestibular hypofunction. I also would like to know if they have non-classical Meniere's disease presentation that, for example, migraine features that would explain a chronic rocking dizziness is often seen in my migraine patients. And those are the patients who have a vertigo attack, but they don't recover. They have this lingering hangover, rocking dizziness as well. So I would screen them for migraine features. I would make sure they don't have any vestibular hypofunction. That would be my next.
So you would do a VNG?
No, depending on my clinical exam, I rarely do a VNG in those patients. If I have a bedside head impulse test that is positive, I send them to PT. If I want to get a little bit more clarity, I do a video head impulse test, same day add on like an audiogram basically, and double check my suspicion.
Okay. And Jeff, what kind of workup would you do for this?
It's affecting both ears. I usually do get an MRI just to check and make sure there's no intracranial pathology. I will do a quick screen in clinic.
Sorry, do you do the special high drops protocol or just the regular one?
We are in the process of getting some scans that are the new protocol, and they're not yet at the quality they need to be. So I'd say it's a work in effort, so it's something I disclose to patients that if they're okay getting a scan that may not have good diagnostic yield, but it would be helpful for our efforts, then we'll do it. If not, and most of them say no when you phrase it like that, then we won't do it. I think there's always a question of can this be driven by an autoimmune mechanism. So I usually will send out a panel of autoimmune labs, and maybe Dr. Vambutas will inform us more what the right ones to send are. I do a quick screen for like syphilis and Lyme just because I'm curious if I could pick up a case of otosyphilis once in my career. And then I think there is a question of genetics here that I don't know the answer to. So I usually don't do genetic testing, but maybe that's not the right thing. And then the final thing I'll say is when someone's dizzy most of the time, I think the most important thing to figure out is why and what's driving the patient's most bothersome symptom, meaning clearly there's something going on peripherally, and I think we do need to understand this patient's vestibular function. So frequently I will get vestibular testing for a patient like this, especially if I see abnormalities on my bedside exam. But I want to know, is their dizziness most of the time being driven by ongoing peripheral disease? Is it migraine? Is it 3PD? Is it a bilateral vestibular dysfunction? Or what's driving their symptomatology? Because that way I can at least try to address that.
And what do you do if he says, well, is it safe for me to drive? Who wants to comment on anybody on the panel?
Habib's doing some work on this, so that's why I looked at him.
Oh, okay.
We don't have any guidelines. We're currently doing a focus group. We're kind of in phase 1 of preparing a dizziness and driving questionnaire to understand the impact of various vestibular pathologies on dizziness ability or perception of ability. So I tell patients to use their best judgment, obviously, and I haven't had, I don't know if others have, I haven't had a patient get a Ménière's attack that leads to a crash. Most of the time you have a little bit of a warning sign, you can pull over. It's about the anxiety of having an attack when they're stranded on the highway, which they will decide if they are able to do it or not. But most of the time I leave it up to the patient right now until we get more evidence or data.
Mm-hmm. Oh, yeah.
Well, I was just going to say, most Ménière's patients have a prodrome, though, that they know to pull over. I mean, I've had patients that have pulled over. I let them drive because they usually know when the attack's coming. They may be stranded, but
Very
you
good
know,
point.
they're not. They're still safe. Is my point.
So it sounds like there's not a consensus that this patient actually has Meniere's disease based on at least what I've given you here. Is there a role for electrocochleography? I'm taking that as a no. Okay. What?
You know, there's so many things. I mean, electrocochleography, there's some people that do it, but the correlation between symptoms, it's the same thing even with just the imaging. You know, most of the time when I get the delayed imaging, I find it's the other ear that has the high drops, not the diseased ear. And so the same thing you find with electrocochleography. I'm just not sure how sensitive it is.
Right, right. Okay, very good. Any other comments on this case?
So I've been getting genetic testing on everybody that has anything that I cannot explain. Now and what's amazing is how many times I'm finding genes that are associated with the cochlea, but it's described as undeterminate. Mm-hmm. And what I found, which many of you may know this, but the American Society of Genetics has a 5-point category of how they classify what is definite correlation. So it's not correlated at all, yes correlated, maybe correlated, probably not correlated, we don't know. And there's this 5 category. Apparently y'all vote on this, is my understanding of how it happens. So my thought is I want to get genetic testing on all these people because now at least we're registering that these patients who have these genetic defects have symptoms. Because if we're not testing them, it's not until you're going to have multiple papers. And as you know, these cases are so rare. But like I just have a patient just like this, a 32-year-old woman, one ear popped up, 4 years later, the other ear pops up. I do genetic testing. She's got 4 different genes that are all associated with some type, that have been reported with some type of hearing loss. And yet at the same time, the tests come back and say, well, but it's not significant. And I'm like, how can this not be significant that she's got these 4 genes that are all correlated with the inner ear? It's just we don't know yet, and the society has not stamped the approval yet. So that's why I do genetic testing, and I tell them probably there is some genetic relationship here that's causing this type of thing.
Okay, let's move on to the last patient. I think we have a few minutes left. Okay. Patient 3, 59-year-old female school administrator. Has had right-sided hearing loss for many years and now has fullness in the left ear. She's kind of dizzy all the time. Habib, you want to start off, interpret the audiogram, and what would you do?
Sure. She has a right severe to profound hearing loss with poor word discrimination almost on all frequencies. And on the left, she has a mild low-frequency hearing loss rising to normal, and then a high-frequency hearing loss in the moderate range, with also reduced word discrimination. Does her fullness in the left ear fluctuate? That would be an important point to figure out. At this point, I'm not thinking of a recurrent vestibulopathy along the lines of Meniere's disease, given just the symptoms we have in front of us. The generalized dizziness all the time, I will want to do a full vestibular evaluation in the clinical exam to make sure there's no vestibular hypofunction and screen for causes of other causes of constant dizziness and imbalance, whether it's a peripheral vestibular cause or a central vestibular cause.
Thank you. Okay, so Jeff, let's say you followed her a little bit, you got repeated audiograms, and the right ear is pretty stable down there, but the left ear is fluctuating up and down. What would you do?
Yeah, I think I was taught that that sort of pattern could be seen with delayed endolymphatic hydrops. So this is the idea that one ear has lost hearing years ago, and then you developed a Meniere's-like syndrome in the healthy ear. And I believe the imaging studies in that condition have correlated that you do see high drops in the ear that's fluctuating now. Generally speaking, most people treat that like Meniere's disease. If she's dizzy all the time, I think we have to figure out, what's driving her symptoms. Because if, she clearly has a vestibular problem going on, sometimes that is what's driving the constant symptoms. Sometimes it's more of a 3PD type mechanism where it's the central maladaptation that's driving the symptoms, because that could be more responsive to an SSRI or an SNRI versus just the standard Meniere's management.
Okay. Bill, she's freaking out. She can only hear out of one ear. She's worried about can she even continue in her job? What are we going to do to save her hearing?
Well, so I think the thing that bothers me the most is that left ear has a 72% discrimination problem, even though the overall pure tones aren't that bad. And as you said, she's fluctuating in this only hearing ear. The right ear, if it's been down and been stable, from a hearing perspective, I would consider a cochlear implant in that right ear. Based on, and then what we do with the dizziness, if we need to do more for the dizziness, that's something to consider. So I would consider a cochlear implant for single-sided deafness. She's not going to do well with a hearing aid in that right ear with that 32% discrim. The other thing that I think is extremely important in these individuals, especially somebody who's 59 years old, anybody who's right around 60, I always tell them, Medicare does not pay for cochlear implants for single-sided deafness. So don't decide you want to wait till you're on Medicare to have it done, even though she's 59 years old, because she's maybe disabled because of this hearing loss and the vertigo. She goes on disability and gets on Medicare, then again, that's a problem from a, just from a insurance reimbursement perspective. So that's one of the things I talked to her about.
Good. Well, sure. So now I guess it's we're going to kind of hold off on this case. Are there questions from the audience about any of the cases that we've talked about today, or basically any topics, because we got the panel of experts right here.
I'm going to make a comment. For all these patients, I think that the first question you have to do is to ask for a familial history, if they have symptoms in the familial history. This is more easy to do than many of the sophisticated tests. And imagine that all these audiograms that you have shown here, they have no history of vertigo, no history of vestibular systole. Would you consider do genetic testing to any of these? I will do in all of cases, particularly the 32-year-old woman. Why are we discriminating patients because they have vestibular symptoms? We should have the same criteria, because just according to the audiogram, all of them deserve genetic testing, and you will be surprised.
I love the discussion of barometric pressure. I was at the University of Iowa for 10 years, and a majority of my Meniere's patients could predict thunderstorms. I moved to Seattle 20 years ago. Nobody notices any variance of weather with their Meniere's disease. And the difference was always incredibly striking to me and has remained so to this day.
But they're just dizzy all the time in Seattle?
No, but we don't
It just rains all the time in Seattle.
The barometer doesn't swing like it does in the Midwest.
Okay.
We don't get thunderstorms in Seattle, almost never.
Got it.
And so you don't see this pattern that obviously they have in South Carolina.
It's like the old farmer says, when I get the bursa in my elbow, that's when the thunderstorms are coming, right?
Yeah. Other questions or comments? This has been a great discussion.
I would make one comment about this last case. I would definitely get a full vestibular evaluation before doing a cochlear implant on the right side.
A VNG.
VNG, VHIT, rotary chair, just to get a full workup given that they have generalized dizziness all the time. And if there is a hypofunction, I make sure that they go to rehab before doing the implant.
Yeah.
Just one question. I'm a hearing scientist, and I work for a hearing aid company. But a couple of years back, I developed dizziness, kind of ongoing, maybe 1 out of 10. And then a couple months later, I started having fluctuating hearing loss, low frequency, very much what you showed for one patient just in one ear, peaking or normal at 2K. And because I'm a hearing scientist, I would just measure the hearing loss every day because I work for a hearing aid company. Sorry. So I could do that in situ, right? and I had fullness and low-frequency tinnitus, so it was suspected Meniere's, tried a couple things, but in the end, maybe 8 months into it, I asked my ENT or my sort of different doctors if they could try a statin. And 2 weeks, 3 weeks into statin, the dizziness and the hearing loss vanished. Have you ever seen anything like that?
So at Northwestern, this isn't Meniere's disease, but at Northwestern, they actually have a statin trial right now for sudden sensorineural hearing loss. So there is some correlation between, and again, I'm blanking on the biological characteristics of it, but there is some potential correlation they found in their basic science labs there, and that's why they went to the clinical trial for it.
Is that just like a lack of oxygen, basically dyslipidemia related, or hypoxia, or?
I don't know.
There's also all that interesting research from Lisa Cunningham about statins being protective of hearing in vestibular schwannomas.
Thank you.
Thank you.
Just a comment. I work in Germany, and we have a quite different attitudes toward driving for Meniere's patients. There's a very strict rule that Meniere's patients with attacks that are not always accompanied by symptoms that arise before the vertigo, they must not drive. And that's a main problem for our patients, because many of them actually lose their job because they cannot reach it.
Yeah. You know, the driving's a tough one. I'm always hesitant to put anything like that in the medical record for fear that it follow the patient around. There was one other point somebody made about being able to, oh, you just made it, about repeatedly checking your hearing test. What have you guys been noticing with like the iPad, iPhone hearing tests? Are patients doing that? Is that helpful?
It's actually fairly good correlation between those smartphone apps and the actual audiogram in the booth. So I tell patients to download the app in clinic and to use it during their episodes. And I kind of tested it kind of in real time. They would tell me they have an episode. They would send me the audiogram. I bring them in, and it correlates. And I've been using it to decide whether I give oral steroids or bring them for IT steroids.
So I was thinking I might just ask, oh, sorry, Bill.
Well, I was just going to comment. So, I had a sudden hearing loss November 22nd in my right ear. Got an audiogram because obviously 1:45 in the afternoon, I have audiologists, kind of like your hearing scientist. I could do that. The Mimi app, I think, is the best app because I've tried several of them. It's MIMI. It's free. It will test their hearing on a daily basis. It correlates extremely well. It's a Beckesi audiometer test, and it works with your AirPod Pros. It's very, and I've actually had hearing tests in the office with the audiologist, hearing tests with my Mimi app, and it correlates so well.
Huh, thank you.
It's only on the iPhone.
Yeah, it's an Apple product or an Apple phone product.
On Android, there's one called Hearing Test. I have less experience with it.
Yeah. Oh, and I've also done the Apple test, and it's also very good too. And I've used the Apple Air Pros for as a hearing aid. It's okay, not as well as a hearing aid, but anyway.
It's just a comment. Maybe it's not a big problem if it's correlates to a clinical audiogram, and just as you have a baseline that you can relate to, so you can see how your hearing will fluctuate if it has a decent retest reproducibility with the hearing test that you're using. So I think it's a very good idea that the patients actually can use these apps, and I agree the Mimi is probably one of the good ones that's out there, but I think there could also be some for other people not using iPhones, using other mobile phones, or maybe even with other types of headsets, because this also will have an impact on where your thresholds will be.
Thank you. So we just have about 2 minutes left, and one of the points of this seminar was to stimulate research in Meniere's disease, and so I thought I might ask each of the panelists if there was one area of Meniere's disease that you think is the most important to study with research. Maybe you could just say what you think it is, and if you can, why. I don't know, Bill, do you want to start?
I would start with diagnosis and etiology, because the problem is we can have all these different clinical trials, and I think what you've shown, what several people have shown, Ménière disease is a very difficult disease to both to treat, and the problem is you probably have just a category of multiple different etiologies in there, and I think we have to figure out what are those subtypes so we can figure out this subtype gets this treatment, this subtype gets this. So I would go to diagnosis and etiology as the biggest issue.
Thank you.
I agree with that. I think as long as we don't know if we're treating the same disorder or 1,000 different disorders, we're not going to make headway in the clinical trials. But I also think we need also a consensus on the outcome measures we're going to use, and these should be set in stone and used in every trial.
Very good. Jeff?
Yeah, I find that I'm just a very concrete thinker, meaning I'm going to leave it to the smarter folks to figure out the pathology and what's actually going on with Ménière's disease. In the current landscape of just having all these treatments that we don't know if they work or not, I feel that it's very important to do well-run clinical trials to figure out if we have a theory, like I presented a theory that migraine's related to Ménière's disease, but it's just a theory. Like at the end of the day, we have to test that with a rigorous clinical trial and figure out if that's true or not, and if it can benefit patients.
Very good. Well, I thank the panelists. It was a great discussion. Thank you.
All right, thank you. And I just want to thank everyone who was our speakers and our panelists for our first half of the symposium, focusing on the clinical side of things. We're going to take a 10-minute break right now, and when we come back, we will be focused on lab science and knowledge gaps. So please do come back, and don't forget that after the seminar, we are going to have a networking session, reception in the back. Also, we have our QR code with the survey. Don't forget to take that. So we will see you back here in 10 minutes, everyone. Thank you. How's it going?
Yes, please.
Yeah. It's been good. I'm gonna do that too. I gotta come back in 10 minutes. I gotta remember to do that.
question, but my wife is a professor here in town.
Oh, really?
And she went to the University of Zurich. She's from Switzerland.
Oh, wow.
Yeah, she's taught here for quite a while.
Oh,
It's a
okay.
big university, University of Central Florida.
Okay.
And in Orlando. And she teaches French, German, English for speakers of other languages, and education classes in general. But she said there was some, when I saw there were some folks from Zurich here, said I've been trying to find who it was. She says, tell them to come over, I've got fondue and I can make raclette.
Swiss community.
I think it's she would say Grüezi.
Yeah, Grüezi.
Well, I've been there many times with her over the 38 years, and I have EU citizenship, because my mother was Dutch. Of course, Switzerland's not part of the EU, but it's expensive.
It is. It is.
When you could live in, like my brother lives in Spain, and really the weather can be a little.
Hi, everybody. We're going to get started in just a couple minutes, so if you want to grab some water from the back, grab a seat, we're going to get started. I'm going to invite the speakers to the second half to come up and join me on the podium. Thank you.
Everything's great. I'm just running a test right now.
Oh, don't panic me.
Nope, sorry.
Welcome. Are you enjoying it? Great.
How can we leave?
You can sit wherever. You are first up, so you're going to be.
The first
Gets you to a much better place.
You're the first. We had somebody who was going to speak. Oh no, you are second. No. Andreas is the first.
Andreas, you're the first.
And then we just need Joanna. I'm going to go grab her, and then we're going to get started.
Yeah.
Freezing. Everywhere I've been walking, it's freezing. It's supposed to be Florida. Well, it's your summer right now, right?
Yeah. But I wasn't expecting this.
Like your summer right now, right?
This Florida is always with good weather. This is what I was thinking in my mind.
So it must be nicer.
Sydney come. Yeah, Pablo's with me.
Oh, nice.
He's,
New York.
PhD student.
Yes.
Yeah. Oh, lovely. Perfect.
Yes.
All right, hello everyone. Welcome back. We're really excited to continue on with our symposium and go into the second half, the lab science and knowledge gap side. It's going to be the same format. We're going to have some speakers. They're going to do their presentation, followed by a little Q&A, and then another moderated panel discussion. So we're going to jump right in, and Dr. Andreas Eckhard is going to talk to us about the molecular basis.
Thank you so much. Thanks for the organizing committee for inviting me to speak here. It's a pleasure. And I want to start out by introducing our fantastic team at Mass Eye and Ear as well. as the otopathology lab at Mass Eye and Ear, where most of our wet lab research happens. So we kind of talked about the prevailing dogma of Meniere's disease already. We heard about different etiologies that we suspect play a role. We heard about endolymphatic eye drops being in the centerpiece as a fluid overpressure, fluid overaccumulation phenomenon that we think causes these symptoms. Well, there is evidence out there in the literature that this might not be true. We see endolymphatic eye drops being associated with a range of other conditions. We can even see it in asymptomatic ears. But still, it is the prevailing dogma that informs our research as well as how we interpret the clinical course of Meniere's disease, shown here on the right side in that diagram with the time on the x-axis and inner ear function on the y-axis. We usually start out with a normal inner ear, and due to endolymphatic eye drops, an overpressure phenomenon that we think stretches these membranes, leads to repeated microtrauma. The inner ear degenerates progressively over time, and there is that phase early on where also, according to the dogma, pressure-induced episodic symptoms occur, the time when we diagnose this disease based on that characteristic pattern. Well, this dogma is derived from analogies to glaucoma, another fluid overpressure disease drawn more than 100 years ago. Meniere's disease back then was even described as glaucoma of the inner ear. But it is important to note that we heard about this in the first session. The therapies that this concept yielded are questionable in their efficacy, and it certainly does not have yielded any cures or causative therapies. But still, we're living with this eye drop-centric paradigm. This paradigm is also the basis for most of the animal models that have been developed for Meniere's disease or endolymphatic eye drops, with the idea to induce overaccumulation of endolymph fluid or overpressure in animals with various methods. We don't know if that really reflects the pathophysiology of Meniere's disease, and even more complicating, we now are becoming more and more aware that this is not a homogeneous disease. We see different subtypes, and that poses the challenge that we also have to figure out which animal model actually recapitulates the pathophysiology of which subgroup. Another approach in research is to look at human ear tissues from patients with Meniere's disease. There should be some ground truth buried in that, because this is the tissue that actually carried the disease. And this is something we do a lot in our lab, in the otopathology lab at Mass Eye and Ear. But also this approach comes with challenges. We know that Meniere's disease usually takes place between 30 and 60 years of age, and by the time these tissue donors decease and the inner ears become available for study, the disease is usually in their burnt-out disease stage. It has ravaged through the inner ear. Degeneration has progressed to a level that hearing thresholds have leveled on a permanent, moderate to severe level. And when we look in these inner ears at the cellular elements like hair cells, the stria, or neurons, in something we call the cytocochleogram, we see that a lot of these cells have degenerated, here indicated by the white spaces in these bars. So we get a very murky picture out of these tissue specimens. And on top of that, these patients might have had a history of occupational noise exposure in their lifetime. They might have ototoxic drugs that cause additional damage. And teasing this apart retrospectively needs an approach, larger studies where we look at a large number of temporal bone specimens at a time. So I want to talk about our research approach towards the underlying etiology and pathophysiology of Meniere's disease that we have pursued over the last 5 to 6 years. and present some of the findings that have led us to think in a radically new way about the nature of endolymphatic hydrops and how it actually ties into Meniere's disease. So we leveraged our human temporal bone collection at Mass Eye and Ear, and we focused our studies on the endolymphatic sac, indicated here in purple. What we found is that the endolymphatic sac epithelium expresses a set of ion transport proteins that are regulated by systemic hormones like aldosterone in order to transport ions and fluid across the epithelium. This is consistent with many previous studies that have been done on endolymphatic sac epithelium on the molecular level, but it really emphasizes that this structure in the inner ear seems to be an interface with our body in terms of sensing physiological needs and probably adjusting inner ear fluids according to these needs. When we looked at the endolymphatic sac in Meniere's patients, we saw consistent pathology in that organ. We saw in some of the specimens we had available that the endolymphatic sac degenerated, and this includes also specimens from rare specimens from patients who passed away during the early course of the disease, not in the late burnt-out stage. We saw other Meniere specimens in which the endolymphatic sac had never fully developed. My colleague Amy Juliano already talked about this. We call this a hypoplastic endolymphatic sac. And we have then developed CT and MRI diagnostic criteria to visualize these different endolymphatic sac pathologies in live patients clinically to tease apart these patient subgroups. And we have used these diagnostic methods in retrospective and prospective studies to show that these subgroups truly have distinct clinical features, and these diagnostic criteria even allow us to predict what's going on, for example, in the second ear of a Meniere's patient, to predict the risk of developing Meniere's disease based on a finding of an abnormal endolymphatic sac. So with these findings, we then pose the question, well, when the endolymphatic sac is consistently affected by pathology in Meniere's disease, how big of a damage is that actually? Because looking at an endolymphatic sac, a human endolymphatic sac histology, it becomes pretty quickly apparent that this is a large epithelial organ. So we went out and using serial sections, hundreds of serial sections from normal and Meniere's affected inner ears, we measured the epithelial surface area that is in contact with the endolymph in the endolymphatic sac, as well as in the other parts of the inner ear, the cochlea and the vestibular system. And what we found, to our surprise, is that in a human inner ear, the endolymphatic sac is truly a large organ, which makes up a third to almost a half of the epithelial surface or cell mass. And when we do the same quantitative analysis in inner ears from Meniere's patients, for example, those with a hypoplastic endolymphatic sac, we saw a massive reduction of endolymphatic epithelial surface in the endolymphatic sac. So the answer to the question is, yes, the endolymphatic sac is a site of major injury in Meniere's disease. An inner ear affected by Meniere's disease sustains a massive pathology in terms of a massive loss of epithelial cells. So with that in mind, we turned away from the endolymphatic sac and towards the cochlea and the vestibular system, where we know hydrops forms, where these membranes expand. And we wanted to revisit the nature of endolymphatic hydrops, focusing specifically on the cells in these membranes, here the Reisner's membranes, the epithelial cells and the mesenchymal cells. And we tested a basic prediction of the prevailing fluid pressure paradigm, which says when the endolymph volume increases and these epithelia get stretched, what it's supposed to happen is that the number of cells should stay the same, the cell count, but because they're getting stretched, they come further apart. The cell spacing or the distance between neighboring cell nuclei should increase. And our fellows, Diana and Chari, who are also here in the audience, they trained a deep learning segmentation model that recognizes these cells and measures the cell spacing between neighboring cells and applied it to a large number of specimens in our collection. And what they found is, indicated here as heat map patterns, the cell count in a hydropic Ménière's ear is substantially higher in these rhizinous membranes compared to a normal control ear. The cell spacing, in contrast, stays the same. So what we observe, and this is the aggregate data from a large number of specimens. On the x-axis, you see all different degrees of hydrops, basically from no hydrops on the left side to very severe hydrops on the right side. And on the y-axis, again, cell count and cell spacing. And we find an almost perfect correlation of cell count with expanding membranes, whereas cell spacing stays the same. So this is literally the opposite what the fluid pressure paradigm predicts. What we see, what we see, the most likely explanation is that these epithelia proliferate. They increase their cell numbers by up to 4 or 7 times. And I urge you to check out the poster that Diana and Chari are presenting on Tuesday with a lot more data on these findings. So how do we reconcile that? We think the inner ear in Ménière's disease sustains a major injury, and we have identified the endolymphatic sac as the site of major injury where cell loss happens. In the cochlea and the vestibule, it seems like the epithelia are proliferating, expanding by proliferation. And to understand what's going on here, we turned to other organs, and you can literally look at every other organ in the human body when here, for example, the kidney sustains injury. The remaining cells leverage 2 mechanisms to compensate for that functional loss. The first mechanism is called hypertrophy, which means the remaining cells upregulate their gene expression. They put more ion transporters, more enzymes, whatever, in their cytoplasm or their membranes to work harder, and they grow their cell surface area. The second mechanism these remaining cells leverage is called hyperplasia, which means the remaining cells undergo mitosis and replace the lost cells. This is different from regeneration. Hypertrophy and hyperplasia replace lost tissue in a patchy way. This is qualitatively minor tissue, and that is a problem. When the initial injury is too big and hypertrophy and hyperplasia have to replace too much tissue with qualitatively minor tissue, this can cause further damage and end up in a vicious cycle, which is called maladaptation. And maladaptation, in the example of the kidney, can then lead from an acute kidney injury to chronic kidney disease. And the clinical course of chronic kidney disease is shown here in that diagram on the right side, with GFR, the glomerular filtration rate, being a measure of kidney health. And you see it progressively degenerates. Maladaptation drives it down to the point where the kidney is basically dead. And phosphate and calcium levels in the blood are a measure, a functional measure of kidney output. And you can see, and they are stable for a long time. And then when kidney degeneration and maladaptation have progressed to a certain level, we end up in the early phase of chronic kidney disease where function starts to fluctuate. The kidney cannot keep up with physiological demand all the time anymore, so these levels start to drop and recover. And when degeneration further progresses into end-stage chronic kidney disease, the function completely ceases. And now, you might remember the clinical course of Ménière's disease I showed you in the first slide, and we can literally overlay this here, starting from a normal ear and ending up in a dead ear with a course of fluctuating function in the middle. So what we think, based on our data, what happens in Ménière's disease is that injury affects the inner ear in Meniere's disease, and the remaining cells in the cochlea and the vestibular system try to compensate for that initial damage. So endolymphatic eye drops, we think, is an active compensatory process that reacts to an initial damage. And the etiology of that injury, like in any other organ, can be ranged from genetic, infectious, ovovascular, and other causes. Clinically, what we see is basically maladaptive progression, right? Losing a third or almost a half of all cells in the inner ear is a massive injury. And the proliferation that happens in these hydropic membranes is probably maladaptive in the way that it drives degeneration of the organ over time. So we go through all these stages, including an early fluctuating phase and finally ending up in the burned out disease stage. So with that, I want to refer to a podium discussion and a poster that my colleagues Divya, Chari, Paula Robles-Bolivar, and Arpan Bose are presenting regarding a group of Meniere's patients with a hypoplastic endolymphatic sac, where we looked further upstream in this pathophysiology, and we think we identified for the first time a gene that is clearly associated with hypoplasia of the endolymphatic sac in a definable patient subgroup. And this translates very nicely into a mouse model that Arpan Bose and Divya Chari are presenting on that poster. I'd like also to refer again to Diana's and Corey's poster, who are showing more data supporting this maladaptive progression mechanism between hydropic membranes and the endolymphatic sac that I was pointing out. And finally, I also want to refer to the poster of our colleague David Beckinger from Zurich, who is exploring the clinical outcomes between different groups of Meniere's patients with regard to CI eligibility or CI indication. Thank you so much.
Thank you, Dr. Eckhard. I believe we have time for maybe one quick question, if anybody in the audience has a question.
Yes, you can hear me? Yeah, so very interesting, first of all. Congratulations on the changing paradigm and suggesting new ideas. I felt I missed something in the Reisner's membrane argument, that you had two types of cells, a mesenchymal cell and an epithelial cell. You showed them on different layers, but then you went to the eye drops condition, and it was only one cell in your cartoon.
Yep.
So what did I miss? Did the mesenchymal cell become an epithelial cell?
Yeah, that's a very good question. I want to say in the cartoon, I just omitted the mesenchymal cells. In our analysis, we analyzed both the epithelial cells and the mesenchymal cells. So the mesenchymal cells on the paralymphatic side. If your question is, are the mesenchymal cells transitioning into epithelial cells, we don't think that's the case, because the initial number of mesenchymal cells in a normal Reisner's membrane or normal saccular membrane, where we did the same analysis, is by far not sufficient to explain the increase in epithelial cells.
Okay.
So we think it's the epithelial cells that are actually proliferating.
Okay, yeah, but are you still counting the two layers, or you're just counting one effective layer when you do the quantitative analysis?
We counted both layers.
Okay.
Yeah.
Okay.
All right, thank you very much. So now I'd like to bring up Dr. Antonio Lopez-Escamez. He's going to talk about genetics, which we kind of talked a little bit about in the first section, but now we're going to hear a little bit more.
Thank you so much for inviting me to be part of this wonderful symposium. This is my disclosure. I have no potential conflict of interest with this presentation, and this is my current grant support. The first thing I want to start with is that we all probably agree right now that Meniere's disease is not a single disease. So this is the first thing that we have to have very clear. We published these studies a few years ago, and using cluster analysis, we were able to identify that there are 5 subgroups of patients. And this is not just an academic classification. This patient has different clinical features in terms of age of onset or associated comorbidities. But that was a few years ago. What we all agree also is that endolymphatic hydro is observed in most of patients with Meniere's disease and has been clearly explained before, is mostly associated with the degree of hearing loss. So it's reflecting the degree of inner ear damage. But other conditions can also show endolymphatic hydro. This is something that we cannot jump into conclusions. So Meniere's disease and endolymphatic hydro are completely different things, but they are associated. What is the situation with what we think we have right now? So we have identified molecular subtype of Meniere's disease. I will skip most of this because there will be a few presentations later, but we already have been able to identify 3 subgroups of patients with Meniere's disease according to the immune response. We have a subgroup of patients with autoimmune. That means that they have a high level of TNF-alpha and low level of IL-1 beta. This patient can be distinguished from the autoinflammatory subgroup, that are patients that are defined for high level of cytokines. They have multiple cytokines, including TNF-alpha and IL-1 beta, but also IL-6 and other cytokines. And this autoinflammatory, we have also shown that are mediated by changes in the gene expression in monocytes. So this is something that we have already consistent data to identify these patients, and this can be distinguished measuring cytokines. And we have a third subgroup of patients that are defined by high level of immunoglobulin E, and these are associated with type 2 cytokines. So there is a set of cytokines that include IL-4, IL-5, IL-9, IL-10, and IL-13 that have a special chronic inflammation. All these patients have a systemic inflammation. I'm not talking about finding in the ear. It's something that we can test making a blood test. It's something that we know. But then there's also a subgroup of patients that their immune response is normal. We think that the majority of these patients that we are estimating that could be up to 40% of the patients may have a genetic origin. And I will dedicate the rest of my presentation to talk about that. So we know that familial Meniere's disease in European population is 9%. So the only thing you have to do is to ask your patient, do you have any relative with symptoms like that? If we do this to patients with hearing loss, why not are we doing the same question to patients with recurrent vertigo? It's very easy. We are missing the familial history of many of them. We know that this familial history, as I mentioned, is also observed in East Asian population, but there the prevalence is lower. And we already know that the most common gene in familial Meniere's disease is OTO, which encodes for autogelin, and I will talk about that later. And what happens is these have, in the majority of the cases, are recessive inheritance. And we have found multiple families exactly with the same mutation. This is called compound recessive inheritance. And the prevalence is highest in European, as I will show later. So there are many genes that have been reported for Meniere's disease already in families. We are estimating about 20 genes for familial Meniere's disease. These are the first 2 genes that were reported 10 years ago, DTNA FAN1368, that was part of the work of Teresa Requena, was of my former PhD students, and I'm not going into the detail, but this is the summary of what we know already about genetics of familial Meniere's disease. There's around 20 genes, as I mentioned. The 3 more common are autogelin, myo7A, that encodes for a hearing loss gene already well known, it's a myosin. TECTA is another gene that is associated with alpha-tectorin, a protein in the tectorin membrane, and the recently discovered gene, GJD3, which encodes for a connexin that you will show that is a very special location. Most of the genes in familial Meniere's disease are still not known, but some of them have been already reported in single families. So there's no reason to continue ignoring that genetics testing can be probably a very good choice to underline the molecular mechanism of Meniere's disease. And this is exactly the approach that we are following from human study to animal studies. So I'm going to be very fast on this. This is how we identify familial Meniere's disease, recessive familial Meniere's disease with autogene. For this, we use something that is a technique to identify burden of rare variation in familial and sporadic cases. And we found overrepresentation of rare variation, rare missense variation in familial Meniere's disease. But as you can see here, in the upper and lower part of this panel, we found that some of the variants were shared also between the familial cases and the sporadic cases. And that was the work of my former PhD student, Pablo Roman Naranjo. So what we have found is that 4 unrelated families with Meniere's disease have exactly the same 2 mutations that I'm putting here. And these patients were not aware of that. And the thing is that they even don't think that that could be a recessive condition, because the parent, of course, as you know, they have no symptoms. This is the audiogram of these different families. And what we found in these patients that were carriers of the mutation in autogelin is that the hearing loss was developed in the first 2 years of the disease. So they usually reach like a flat hearing loss involving of all the frequencies in the first 2 years. Most of the patients in our familiar patients our series were also female. So these are just one of the pedigrees that we have. One thing I would like to say is that we continue extending our study in the core, and we found more missense variant. And we found that this enrichment was confirmed in more familial cases when we compare with the different population. This is the image of autogelin protein. We have found that most of the mutations are located in the head and in the tip of the tail of the protein. Autogelin makes dimers, makes homodimers that have antiparallel distribution. And we have found that 5 missense variants could alter the autogelin stability according to different predictions. And 8 of these variants were enriched in non-Finnish European population. The relevant thing here is that we think that one of the potential explanations that familial Meniere's disease is more common in European is because one of these variations may have a founder effect in these families. And one of the interesting things that we were also doing, and this is part of a poster that we will be presenting also, is that 6 variants were found in constrained region. That means that this region in the sequence of the autogelin gene cannot tolerate mutation, and this is not observed. This is also that is observed in many of the populations, but not in other populations. Probably this low tolerance that the European has may explain this accumulation and this potential founder effect. Another of the genes that we have also found is MYO7A. We have found 9 families. 2 of them have autosomal dominant inheritance. There's a start loss and a stop gain mutations. These families have a second variation that can explain biallelic inheritance. And we have found an association between one mutation in MYO7A and another protein that are in the stereocilial link that have a direct interaction with MYO7A. And this is how we think that probably this explains something that was mentioned before, how variant of unknown significance can explain the association with the disease, because probably the software is only looking for a single variant. We are not looking in this report that you can find for genetic diagnosis service for multiple variants interacting in the same individual. That this digenic and polygenic combination is something that we have to consider. So this is what we found in this family. Just for example, family 2 have a variant in cadherin 23 and also a second variant in MYO7A, and this is something that we observe through different families. So each family has a different pair of combination, and this is how we explain the association between MYO7A and a second gene. The third gene I want to mention is TECTA gene that encodes for alpha-tectorin, which is a protein of the tectorial membrane, and we observe the identical missense mutation in 2 families, and also we found for the first time some insertion, some deletion in 2 of these families. So this is the finding for the alpha-tectorin, and this is the highlighted variant that we have found in family 1 and family 2. So what happens in this mutation is well known for knockout mice. We know that the deletion at the end of this protein has an effect that leads to a limbal detachment of the tectorial membrane, or a tectorial membrane slimmering. And probably what we think is that makes a tectorial membrane very fragile, and is really a structural changing. So this TECTA deletion has been observed, as I mentioned, in the mouse model. What happened is that the tectorial membrane detached from the stereocilia, and that can explain the hearing loss that they develop. All these findings, as you have seen, leads to an accumulation of mutations that are located in tectorial membrane, stereocilia, tip links, and other links between the different stereocilia, about the idea that probably we need some kind of environmental factor that may trigger the disease. And we think that probably noise could be one of the triggers of the disease, because noise has been already associated with the development of endolymphatic atrophy in a very short period. And we think that the association, the carrier of this rare mutation, have a high risk to develop the Ménière disease phenotype if they have exposure to noise. Finally, the last thing I would like to mention is GJD3 that encodes for the connexin 23.9 that we have found in familial and sporadic Ménière disease. We have found this mutation in a total of 18 individuals, 3 unrelated families segregating the variant, and the variant is a complex sequence that includes an haplotype including 2 missense variant, a synonymous variant, and a downstream variant. So this was found in familial and sporadic cases. This I would like to remark. If you see, the allelic frequency of single variation is very high. However, the combination of all of them is what we have found that is associated, and that was not found in the reference population. What is the effect of this? We think that the protein becomes unstable. You know that connexin makes hexadimers, and you need two connexons to accoplate between 2 cells. And what happens is probably the interaction between the 2 connexons is involved, and we think that probably that creates an unstable connection. This is what the protein is predicting, and that was published last month. The most surprising finding for us is that this connexin is located in the tectorial membrane, and this is something really unexpected. But we think that this connexin is probably related with the interaction between the tip of the stereocilia, and this making some kind of channel that has been already reported relating to the calcium microenvironment across the mechanotransduction channels. We have seen also other labelings in the stria vascularis in other areas. And finally, I would like to finish with some comments about the genetic structure of sporadic and familial Ménière disease. We have extended our exon sequencing study to sporadic cases already, and we have found that there is a burden of missense variant in all the genes, that this is also observed in all genes that are associated with the audiovestibular phenotype, but particularly in genes that are associated with stereocilia and tectorial membrane. So we think that really it's not a single gene. We already know that there are more than 20 genes, but for sporadic cases, probably there are more genes involved, but most of them are located in this structure, and that's what will lead to the hypothesis that probably this fragile ear is able to develop the disease. So we have a burden of missense variant. There are about 71 genes that are shared in sporadic and familial Ménière disease, and that is an estimation about 28% of sporadic cases. So this is how we think that 10% of familial cases, but about 28% leads to close to 40% of cases that may be a genetic etiology, may have a genetic etiology. So I will not go in much more detail with this. Just to say how are we working with this high inheritance in familial Ménière disease, we are developing a machine learning model, and just using genomic data without any type of clinical data, we are able to classify about between 17 and 28 patients with sporadic Ménière disease as familial Ménière disease. So this is what is the model doing, and we think that we have really a hidden hearing loss. We are here excluding the familial case. We know that the familial are very easy. All we have to do is a good clinical history to identify the families, but some of the sporadic probably are according to this model. And in this particular model, we are only using coding regions. We are only using exon sequencing data, and that's probably something that we can improve with the addition of other omics, including transcriptomics and epigenomics, as we are currently working. So the genetic structure of Ménière disease is complex. We may have different structure in familial and in sporadic cases, but we are starting to deciphering this complex structure. And just to summarize the last thing, I would like to think that we are trying to build with all this information a human atlas for Ménière disease gene and cells. And this is one of the main goals. We would like to provide a tool that can be used for the future use for researchers and for the diagnosis of Ménière disease. I would like to thank all the funding that we have been supporting, previously funding with my research group in Spain, and now in University of Sydney in Australia, and all my current research lab that is growing very fast. Thank you so much.
Are there questions?
Sure, I have one.
Thanks for an amazing talk. How do the genetics influence the odds of bilaterality?
Yeah, so we have found that within the families, which is a very precise phenotype, in the same family we have patients with bilateral and unilateral sensory nerve hearing, and they share the mutations. So we think that the development of the disease in one or the second year is something that is mediated by some environmental factor. According to that hypothesis, it's very easy to expect that the disease can be developed in the second year when we look for endolymphatic hydrogel using MRI. We don't know.
So, Antonio, that was a beautiful talk. You started out by talking about different endotypes for Ménière's disease. How does the genetics correlate for cytokine expression? Have you started to look at that?
Yes, one small work that we are doing. So this is one of the things that I'm very interested, because we think that some of these autoimmune phenotype, particularly the autoinflammatory phenotype associated with high levels of IL-1 beta, we think that could be related to very rare mutation in some specific genes. So we have one thing, but it's still not published. But this is, of course, an area that we are exploring, try to explain if rare mutation can drive this autoinflammatory or maybe this allergic type of response. Yeah.
And then we have time for one more question.
Oh yeah, two quick questions on the detector mutant. You seem to only have characterized that in the cochlea in terms of changes in the membrane and then changes of the hair cell stereocellular insertion, but that doesn't explain the vestibular system symptoms. So
yeah, no, I disagree, because let me explain. Autogellin is highly expressed in the vestibular system compared to the organ of Chari. The thing is that honestly, nobody is doing too much histology in this, and we don't know that this is something that we really need to do. But we are expecting that the change that we have presented for the detectorial membrane can occur in the autolytic membrane. And there are studies demonstrating that this focal detachment of the detectorial membrane can trigger changes in the depolarization of the hair cell.
Okay, and then quickly, this is just a change in the kind of mechanical properties of that membrane or attachment as opposed to an ion transport problem. So would you expect this patient not to show high drops?
I think that we cannot explain the development of eye drops with this. The only thing that we can explain with these structural changes is that probably the mechanotransaction will be impaired somehow, and we think that maybe the gating of the mechanotransaction could be altered. From my point of view, that could explain acute tinnitus. That is something, because that changed, but that could also explain acute episodes of vertigo. But we cannot explain how this structural change leads to the final eye drop. For my view, eye drop is something that you need a damage in the ear to develop that, some kind of damage.
Thank you very much. That was really, really interesting. Before we move on to our next speaker, just a little housekeeping announcement. We did have coffee now in the back, so if anybody wants to quietly get a cup of coffee while the presentations are going on, please do so. So now we're going to hear from Dr. Andrea Vambutas, who's going to talk to us about immunology and Meniere's disease.
Thank you so much for the invitation to be here. And here we go. So I'm going to talk about the immunologic aspects of Meniere's disease. However, inherent to this is we really need to talk about autoimmune inner ear disease as well. So for people like me who went to medical school quite a long time ago, immunology has changed pretty dramatically in the sense that we used to think of autoimmune diseases, but there's a whole new class of diseases called autoinflammatory diseases. And these are really diseases of monocytes, macrophages, microglia, where they make IL-1, they make TNF, but they really don't make any autoantibodies. There's no Th17 cells or other cells. And so many of the talks that you've already heard and talked about cytokines being produced are being produced by these monocytes and macrophages. Together, we also know is that several common diseases that we used to think of as autoimmune have actually now been reclassified. Most commonly, gout and Behçet's disease are really now considered to be autoinflammatory, where they used to be autoimmune. And so that really calls into question diseases like autoimmune inner ear disease and Meniere's disease. What are they really? Because honestly, we don't have autoantibodies in many cases. And so do they represent an autoinflammatory disease? Are they a multitude of diseases? And that's been a theme today, and it's absolutely correct because doesn't seem to be any one common disease phenotype. The other thing that I want to point out to you is that symptoms of classic autoimmune diseases and classic autoinflammatory diseases are very, very similar. So for instance, if you take the example of Cogan's disease, which we know responds to TNF and really is considered to be an autoimmune disease, these patients have hearing loss, they have vertigo, they have interstitial keratitis. However, patients with autoinflammatory disease also have hearing loss, they have uveitis, they have headaches, and they have vertigo. So you can't distinguish them based on their clinical phenotype alone. So what I'm hoping to suggest to you is that in some instances, Meniere's disease, as we know, classically has hearing loss together with vertigo at every single episode. However, in patients with autoimmune inner ear disease, they have fluctuating hearing loss, and at 50% of their presentations have vertigo. The case Dr. Oghalai showed you earlier of the patient with a fluctuating hearing loss who didn't always have the vertigo, is that Meniere's disease? Is it an atypical Meniere's disease? Is it autoimmune inner ear disease? And I would have charged to you, maybe these are a continuum of the same disease. So we know, and classically, the history of Meniere's disease is that it's really regulated by sodium potassium ATPase and the stria vascularis. However, glucocorticoid receptors stimulate the absorption of sodium, so maybe that's how we can explain some patients respond to corticosteroids or not. But we also know from the early work of people like Jeff Harris and others, the endolymphatic sac is really thought to be the antigen processing center of the inner ear, so we really can't discount the potential role of the immune system. Additionally, and this was a lovely picture and a paper that I really would charge everyone should take a look at in eLife, showing the regulation of volume of the endolymphatic sac was controlled by a transcription factor of the LMX1BB mutant. And notably, that family of mutants actually can be controlled by TNF and interleukin-1. And so there still may be a role for regulation of endolymphatic sac volume associated with inflammatory response. So I look at things from a slightly different lens. I look at it from the ability to respond to corticosteroids or not. And so we know in patients with Ménière's disease, and this is work that's been published quite a while ago, we know that the corticosteroid response rate is much lower in Ménière's disease than it is in autoimmune inner ear disease or sudden hearing loss, and it hovers in the mid 40% range. And so one of the things that my lab has been doing is looking at, in patients that are corticosteroid resistant, do they have a different clinical phenotype? Do they have a different set of cytokine expression? And can we really capitalize on that? And so what we found initially is that in patients that were corticosteroid resistant, they expressed high levels of interleukin-1. We repurposed anakinra, which is an IL-1 receptor antagonist, to treat patients with steroid-resistant autoimmune inner ear disease. And then recently we discovered that these patients process interleukin-1 differently. And the point of how we're going to get back to Ménière's disease, I'm hoping I'll make evident. So this was work by Antonio Lopez-Escamez that very beautifully pointed out that we have multiple phenotypes in Ménière's, and he already covered this, so I'm going to skip over this for now. But the data clearly points out that as we study these patients in clinical trials, that we really need to have very rigorous inclusion criteria, as Dr. Rizk pointed out. Otherwise, we're going to really be comparing disparate patients and really not seeing the signal we need to see. And so this is work by multiple different labs. Dr. Rizk told you earlier that in patients with Ménière's disease, they have high levels of TNF-alpha that's shown in the top left. From Dr. Lopez-Escamez's lab, they've shown that exposure to mold results in high release of tumor necrosis factor alpha. And in my lab, what we actually found is in patients exposed to environmental molds, that the mold protein and the inner ear protein coquelin are highly homologous, and we get cross-reactive Th17 cells, which suggests that for some patients this does have autoimmune phenotype as well. And then finally we characterized them looking at a whole group of immune-mediated hearing loss and found that in these patients that are corticosteroid responders start out with very high levels of TNF, and then post-treatment those levels drop following corticosteroid use, whereas in patients that don't respond to corticosteroids, the TNF levels were low. So again, this is work from Antonio's lab, and it points out several things that I'd like to show you. One is that early-stage Ménière's disease and late-stage Ménière's disease are very, very different in terms of cytokine expression profiles, and it begs the question whether these are two different diseases or whether the disease changes over time. Because in autoimmune inner ear disease, we know that patients in the beginning of their disease process, 70% respond to corticosteroids, but if you follow them out, and this was done by Broden and Meyerhoff many years ago, by 3 years, only 14% of patients stay responsive to steroids, which suggests the immune system is changing in how it's reacting to these antigens. Additionally, we've spent a lot of time today talking about migraine. And a lot of the data now emerging in migraine is it can be a result of inflammasome activation and interleukin-1. Again, not all patients with migraine may have interleukin-1 associated with it, but we do know now from the neurology literature that there is a very clear role for interleukin-1. So I started out by talking about autoinflammatory diseases, and the quintessential autoinflammatory disease is something called Muckle-Wells. It's a gain-of-function mutation in a gene called NLRP3, and it results in excessive interleukin-1 beta release. These patients, interestingly, have sensorineural hearing loss in the high frequencies. You can stabilize them by treating them, but for most patients, their hearing does not improve. So the entire family of autoinflammatory diseases have a fair number of neurologic manifestations, and many of these patients, greater than 70% in one study, greater than 90% in another, their symptoms are manifest by headache or migraine. And so the inflammatory connection is very alive and real in these patients. And I completely agree with Dr. Lopez-Escamez that we really need to genetically sequence a lot of these patients. One of the things emerging in the autoimmune literature is that, believe it or not, sodium salt actually exacerbates autoimmune disease. This is shown most commonly in patients with multiple sclerosis, and in a cohort of relapsing remitting MS, there was a very positive correlation between disease exacerbation and sodium intake. This is clearly a very nice correlate to Ménière's disease. And so we identified that patients with autoimmune inner ear disease process interleukin-1 differently. Usually, pro-interleukin-1 beta should be cleaved by caspase-1 to 17 kilodalton product. We identified that almost uniformly, caspase-7 cleaves interleukin-1 to a 28 kilodalton product. And notably, in a cohort that we looked at with Ménière's disease, we took their peripheral blood immune cells and stimulated with increasing amounts of sodium salt and saw an increase in interleukin-1 beta transcription as well as release of interleukin-1 beta. And interestingly, in the lower right panel, when you treat the cells with diazide, you actually could reduce that interleukin-1 processing. And then in panel C, just like autoimmune inner ear disease patients, what we saw is that these patients in exposure to sodium salt made that 28 kilodalton product. To me, representing that autoimmune inner ear disease patients and Ménière's disease patients are very similar in how they're processing interleukin-1. Now, granted, clearly not all of them, because we saw that not all of them did the same thing, but a subset clearly do. So recently, one of the residents in my lab also decided to take a look at beta-histine because a number of patients clinically say they respond to beta-histine very nicely. And whereas we found that beta-histine had no effect on these peripheral blood immune cells stimulated with salt at the transcriptional level, we saw that it very nicely blocked interleukin-1 beta release when you co-cultured the sodium salt stimulated peripheral blood immune cells from these Ménière's patients together with beta-histine. And so the other thing that we had looked at was that interleukin-6 is downstream of interleukin-1. And we saw that if patients expressed interleukin-1, that their IL-6 expression followed suit, and we found higher IL-6 expression in response to salt, again blunted with beta-histine. But in the patients that really expressed no interleukin-1 to begin with, they really did not have the effect with IL-6, which foots back to the original discussion that we have patients with multiple phenotypes. And so it really behooves us to characterize those patients and figure out those patients that really express cytokines and would benefit from things like beta-histine or anakinra or other things. So we are currently engaged in a phase 2 clinical trial of anakinra for corticosteroid-resistant autoimmune inner ear disease and corticosteroid-resistant Ménière's disease. This follows the same clinical trial design as our earlier published study, but however, in this instance, they receive anakinra at a 2-to-1 ratio, and it's a crossover. So 84 days of treatment, so equivalent to 3 months. Inclusion criteria that they have Ménière's disease, they have to have a normal MRI, and they have to have failed corticosteroid therapy. And exclusion, we do sequence all of them to look for Muckle-Wells syndrome and genetic mutations in NLRP3, and obviously if they've received any other immunosuppressant agents. So this is actually what the trial design looks like. I'm happy to report that we're about more than 2/3 and almost 3/4 recruited. We've passed the futility mark, meaning we've looked at the blinded data and clearly see a signal between the arms indicating that we seem to see responses. Now, whether this correlates indeed to drug therapy or not, we don't know at this point. But what you see on the right side are patients from our early stage clinical trial where the number 1 is the time of treatment start, number 4 is where they came off of drug, and then we follow them for the remainder of the year. And then take a look in blue. What you see is their pure tone average. The numerical value is their speech discrimination score, and in green is their interleukin-1 plasma levels at the time of each study treatment. This was a trial that was prematurely halted by our Data Safety Monitoring Board because we reached the endpoint far earlier than we ever anticipated. We anticipated a 30% response rate, and we saw a 70% response rate. And then if you take a look at the magnitude of the response on the far right, and we published in 2014, in anakinra responders, the pure tone average improvement was significantly better than the serial audiometry trial, where they looked at the effect of steroids in autoimmune inner ear disease, and similarly the word recognition score also improved pretty dramatically. And so I'm hoping we will be unblinding this trial within the next year, and we'll be able to look at autoimmune inner ear disease, Meniere's disease, and hopefully have some better answers for all of you. So, in summary, the way that we hypothesize autoimmune inner ear disease and subsequently also Meniere's disease, in that in patients that are corticosteroid responses, they have high levels of TNF to begin with, and it drops in response to that TNF, but they're corticosteroid responsive to begin with. Whereas patients that are steroid resistant, they have very low TNF levels, they have high IL-1 levels, and they respond very nicely to anakinra. And just as a side note, there are other IL-1 inhibitors out there. We have tried a number of them and really have not seen the same responses that we have seen with anakinra. And at this time, we don't understand that. But anyway, I want to acknowledge everyone in the lab who's worked so hard at this, and it's been a long work in progress, so thank you.
Are there questions for Dr. Vambutas?
You mentioned sodium chloride cleaving IL-10, was it? Or?
One,
IL-1,
yes,
yeah. Do you understand the mechanism for that?
So we actually really do not understand the mechanism. What we think is happening is sodium salt, just like any other factor that stresses the cells in autoinflammatory diseases, such as in gout, it's uric acid crystals or other things. We think that that is a single stimulus that is causing the cleavage of interleukin-1 to create a pro-inflammatory environment.
Where's the cleavage occurring?
So the cleavage is occurring upstream at, I can go back to the slide, but it's amino acid 28, between 27 and 28.
And I was meeting inside the cells or an extracellular fluid?
So we believe this is occurring in monocytes.
Okay.
Hi, that was great, thank you. I was curious if you know what are the cellular players responding to IL-1. Do you know where the receptor is located?
So that's a really, really good question, because part of this is we're looking at peripheral blood immune cells. We're not looking at the inner ear. We're actually looking at two potential models right now to try to answer that exact question.
Great. Thanks so much.
Sure.
Any other questions?
So I have a question regarding the mechanism of beta-actin to reduce. Do you have any idea? Have you done any?
No, we actually looked at histamine receptors. We looked at a number of things, and we so far cannot figure out how that works. And it's interesting because it wasn't all patients. There's some patients that do not respond to beta-histine at all, and others that do.
But this is something that is only observed in the patients that have high level of IL-1 beta.
Yes.
And not in the other one.
Yeah.
That's amazing.
Okay, thank you.
Thank you. So far today we've heard about drug responses, clinical responses, imaging, molecular, but now we're going to hear about another important topic, the psychological and social triggers with Meniere's disease from Dr. Joanna Wolfson.
All right. Everyone can hear me okay?
We have a lot of
Okay. So first, thank you so much for inviting me. I'm shifting gears a bit, and first thing is I'm not a physician, I'm a psychologist. I work at NYU Rizk, and I work in one of my roles as part of a vestibular disorders clinic. So it's been a privilege to be here. I love interdisciplinary care, so for me it's nice to not be at just a psychology conference, but really learning from physicians, and I hope, vice versa with this talk. Okay, so first I have no disclosures. And the learning objectives today are to identify the psychological and social stressors of living with Meniere's, to really recognize the interplay between the stress response and Meniere's symptoms, so really the way that Meniere's can cause understandable stress, and that stress has its own symptoms that can really loop back into the way that Meniere's can exacerbate or kind of be cyclical, and then to understand how psychological interventions may help people to improve symptom management in particular. And just to point that this doesn't have to mean that people need to be referring all the time to psychology, but really just thinking about what can people do in even a given bedside interaction or just a routine appointment with language that they might be able to say to help someone with some of these interventions. So first, I just want to acknowledge a lot of the different stressors that people who deal with Meniere's disease face, and some of these are really based off of the patients that we see in our clinic, so whether it's an individual therapy or we run a vestibular stress management group. So these are the themes that come up a lot. The first, of course, is just the traumatic nature of symptoms. So people say just not knowing when I may have another vertigo attack, a drop attack, just walking around with this experience of one eye sort of open a lot of the time to my safety, which is very tiring. And then some have had this traumatic medical experience in the pursuit of getting a diagnosis. So I think Heather mentioned it earlier, just kind of getting worked up for all sorts of different scary sounding diagnoses, whether that be a stroke or a brain tumor or other, of course, scary sounding neurological or immune conditions. And so sometimes people may have a PTSD-like response to just where this all started and thinking that they were dealing with something Meniere's, but maybe even more life-threatening. Uncertainty about the future is something that comes up a lot, so of course worry about the progression of all this. And at one point I was able to speak just for one session at a support group for people that actually any vestibular condition, but were out of work as a result of their condition. And they sent in questions ahead of time. I just wanted to read a couple that people sent in. So saying that they worry that it will affect their ability to play with or help their future grandchildren. So these may have been people in their 40s thinking about when I'm a grandparent, what will my life be like? And then, worry about can I drive? Is that safe? And people wondering how to live a full life, even if these vestibular symptoms never fully go away. So people can have all sorts of images of becoming, completely dependent on a spouse or just how this all kind of transpires. Loss of the life that used to be. Many have had very active and vibrant lives before this, and so they know what it was like to feel better than this. And the hidden disability quality is pretty big, so not being able to have someone else just take their body for a week and really get what this is all like. Some say that they may have a good day, they go out to dinner with a friend, and the friend may say, "Oh, you're okay now." And so just this idea that no one really fully understands exactly what this has been like. And lastly, sometimes if symptoms are dismissed by providers along the way or friends as just anxiety. So just a note about vestibular dysfunction and mental health in general. So there's really a high degree of distress associated with dysfunction. So 30 to 50% of people with any vestibular dysfunction do end up having a diagnosable mental health condition, often as a result of the stress of the condition. 80% or more report worsened quality of life. And then specific to Meniere's disease, anxiety and depression are very highly prevalent. Studies show that usually between 50 to 60% of people with Meniere's do experience some level of anxiety and depression. And when we think about rates, if we are able to kind of parse apart what's a pure Meniere's versus migraine versus BPPV or other conditions, rates are higher with Meniere's disease. And I'm thinking about two patients in particular, one who said that she had Meniere's and she had at one point a sudden drop attack in a Trader Joe's. Many people in the US may know what that is. And so, kind of being shopping and then being on the floor the next minute. And then someone with BPPV who said she kind of figured out that she's triggered in the mornings after sleeping, and so all she would have to do was just, prop a lot of pillows up, and then she'd be okay. So just the level of control of varying diagnoses can feel very different. And over 50% of people with Meniere's do report on self-report measures severe levels of anxiety versus only 3% in BPPV, and 20% will report moderate to severe depression. So in terms of correlates, I think it's really tough because as other people were talking about just difficulty with classifying how do we run a study or how do we even place people into a Meniere's group. So a lot of these are just kind of studies that exist where data is still out a little bit, but patients report vertigo to be the most intrusive symptom, causing the most distress on the whole. Tinnitus and anxiety are highly correlated, so about 90% of people with tinnitus will report some level of anxiety. Anxiety is usually higher than depression in the Meniere's population. And there was one study I want to highlight. Again, it was just one study, but they did use a statistical analysis to help understand causation. It was large, based in Europe. As we heard, maybe highest incidence rate, in Europe of Meniere's. So it was 350,000 people of European descent, and looked at the relationship between anxiety, depression, and Meniere's. And so the first thing is they found that purely having pre-existing anxiety and depression does not seem causative. Many people may have had it, but it's not causing this to happen. When they looked at something that was called neuroticism, which kind of gets a bad rep, but it really just means being kind of reactive to stress. So they used it to mean, reactive to stressors that may come up. They saw that it did present as a potential risk factor. And so that was in particular things like being sensitive to environmental and interpersonal stress, and people might even report having always felt lonely, experiencing mood is fluctuating, maybe having their feelings easily hurt, and then being sensitive again to kind of like interpersonal interactions. We do actually show patients this in our support group, just how a vicious cycle can emerge, and this is talked about in some articles where people may have these symptoms on the top. It could really say anything, but let's take vertigo, dizziness, tinnitus, and then, that causes the brain to have this detection of danger, of threat, wondering, am I okay? It's a stressor on the body. And then that leads to a state of hypervigilance, more anxiety, sometimes panic, and then all of that can really just play back into the dizziness and make people feel even, more symptomatic. I like this as well. It breaks it down a little bit more. I'm sorry, it's a little busy, but the things that we really try and highlight for people are that whenever someone's in a state of stress of any kind, the first thing that we all do is hold our breath. And often that's a way to kind of prepare ourselves to fight or flee. And so many people with Meniere's and other vestibular conditions are not running away or fighting when they have this. So they then have extra oxygen in the brain, which can lead to feeling dizzy and lightheaded. And so we just kind of talk about the science behind it and how does this present and how can it exacerbate symptoms. Similarly, muscle tension. If people are especially tensing their shoulders and their neck muscles, it can be a tinnitus trigger, a vertigo trigger. And that when we're under a state of fight or flight, our pupils will dilate to let more light in. However, if we're in a busy environment, it might feel very overwhelming, and then we're overstimulated and everything feels harder to manage. And racing thoughts is common. So if there's like an emergency situation, we want to know where the exits are and think our way out of it. But it can present as just being overly anxious and an overly anxious thought spiral. I want to do this very quickly, but a patient I'm currently working with, an example, he's a white male in his late 60s. He was a reporter in New York, and he worked a lot, like 60-plus hour work weeks. He has a 20-plus history of Meniere's. The symptoms are listed, and he's been to many, what he would describe as like many top doctors at many top institutions where he's just really feels like he's gone through it all. And I know, the quote earlier, I think from Dr. Bigelow was that, it's not that the more treatments, the more success. So he's been through a lot, and he identifies, his symptom triggers are what people were saying earlier, sharp weather changes, noisy environments, but periods of stress. And so before kind of a recent exacerbation, which brought him to psychology, he had this experience of having a long-term job that was highly focused on COVID reporting. And he was responsible for reporting on COVID-related deaths at the start of the pandemic, so a very upsetting position to be in. He ended up, because of his condition, retiring earlier than planned, and while he identified his job as very stressful politically, he liked it. And so this wasn't how he imagined sort of going on with his life. And his wife's father had been ill, actually recently passed, but it had meant she was traveling a lot away to be with him, and so she was really his safety net. And so he had a lot of just stress that he viewed as possibly, involved in some of the symptoms that he was experiencing. And so his quality of life, feeling depressed, anxious, and having panic attacks, started to avoid a lot of things, and partly because of his symptoms and partly because of that reduced confidence, whether he felt he could do it or not. Interestingly, he found this interesting, which he shared with me. He found that in his yard, if his neighbor happened to be there, in between houses, he could talk to that neighbor spontaneously for hours and be okay. But if he knew there was a planned get-together, even if it was in a very controlled, not noisy environment, he would feel very anxious in advance, vigilant to his symptoms, and experience symptom exacerbation even before he got there. In terms of psychological intervention, so it's not, again, there's not studies that say here's what you should do with someone with Meniere's, but there is really good research on tinnitus in particular, and I'll show in a minute a slide on that. And then even with the PPPD, so a lot of these concepts do relate to the Meniere's population as well, just how do we sort of prevent that superimposed stress response on these symptoms. First, again, just sometimes explaining that vicious cycle and the fight or flight response. I've never had patients say they don't believe in it or that they respond poorly to it. They seem to really appreciate the science of it. Relaxation and mindfulness, we heard today a little bit about that mindfulness-based stress reduction, but it could be anything. Deep breathing, people like relaxing their muscles. I really highly recommend, just language of the CBT nature. So just really developing alternative ways of responding to symptoms. So an example is, this is from a patient, had an idea that if I leave home, I will have a vertigo attack, fall down in the middle of the street, and be in severe danger. And so just to be able to get it kind of into check a little bit, that's a really scary thought, and we can't say that won't happen, but just a different thought would be my symptoms can feel very scary, but I've never been in a life-threatening situation. Similarly, for tinnitus, there's a lot of examples, and one from the manual for tinnitus is if my tinnitus is loud when I wake up in the morning, I know I will have a bad day, versus saying something like, I'm learning ways to have a good day even when my tinnitus is loud. And then, helping people find ways of getting back to things that they enjoy safely that feels doable. So not having this idea that I have to have no symptoms to engage in an activity, but that I might have symptoms. And it doesn't mean that I will be in danger, but the goal is to do it even though I have some level. So acceptance and commitment approaches, I think this is the hardest part, is accepting a new normal and accepting that this isn't necessarily something where there's an off switch. So accepting that there's a level of symptoms as part of one's life usually goes better than trying to keep fighting against it and kind of spinning the wheels with seeking care over and over. So this I just want to show everyone. This is publicly available through the Veterans Affairs Department website. They obviously have a lot of ways of been getting funding for care. So I direct patients sometimes to this workbook, and it has a lot of good interventions specific to that for psychology. I just lastly want to talk about barriers and considerations. So these are things that could potentially kind of get in the way of people getting better. By the way, did the volume change, or it's still okay? It changed.
I think the echo is back, but we're looking into that.
Okay. Is it okay to keep going, or I can stand a little farther away maybe? Okay, so some of the things that really can get in the way of care for people in a mental health capacity, and I think I'm not even speaking to an audience I need to be because everyone's here because they believe in the condition, but sometimes if people experience that others don't know what it is, or they don't really buy into the whole inner ear disorder, just feeling invalidated, I think I really can't kind of overstate the importance of the patient-provider relationship, and that a lot of research on a lot of different conditions shows that when people have a good experience with their medical provider, meaning they believe that the person wants them to get better, is kind of caring to figure it out with them, speaks to them as a partner and is there for them, they do better. And that's shown like in a lot of studies. When we think about the placebo effect, a provider has to be involved in the placebo effect. And again, kind of pursuit of a cure where they're just sort of going for more and more and more opinions and treatments. So considerations for all of us might be things like, messages about the condition. How are we phrasing it to patients? Are we off the bat saying there's no cure for this, calling it progressive? Or might we say something like, hearing loss is something you might deal with, but there are ways to manage the symptoms associated with it. Thinking about if you're gonna involve psychotherapy, how are you making a pitch for it, and at what point does it enter the picture? So I was talking to Dr. Rizk earlier, and we were talking about how if a patient hears at the end of like a 2-year search where nothing's working, if someone's then kind of saying, maybe psychology would be helpful, that seems to be a little more, of a hard sell than if it's sort of woven into the team or identified as something that could be helpful for symptom management from the start. I'm just gonna move on for the sake of time. And so options for, again, some of these things can just be done in a routine interaction, but sometimes people may want a little more psychological intervention. And so I always think first about if people are in a larger medical system, are there options there, whether it's social work, psychology, et cetera. Referring to a clinic, that's a hard thing to do sometimes, but if someone practices health psychology, rehab medicine psychology, or a geriatric provider, there's a lot of like telehealth options now too. And lastly, a lot of community or online support groups, I think kind of interpreted with a grain of salt depending on what they are, but the VeDA website has one specific to Meniere's disease. So summary, that it's a very stressful situation obviously to deal with. People do become prone to anxiety and depression, but it's not the cause. And then these symptoms and psychological distress can enter into the vicious cycle, which complicates the symptom picture at times or figuring out what's causing what. And then we know that relaxation, CBT, reducing avoidance, and acceptance are good intervention points. And again, just the positive patient-provider relationship really helps patients feel hope and support. And that's all, so thank you.
Are there questions for Dr. Wolfson?
Sure. Thank you for a great talk. I found it really exciting. One of the things I found in my practice, and it may just be the patients that I see, but the patients with Meniere's disease tend to be more, I hate to use the phrase, but white collar versus blue collar. Do you think that fits with the stress, anxiety thing?
Actually, when I was seeing the previous panel and all the patient examples of like the store owner, the lawyer, I think the administrator, my first thought was like, do they have help? Or is there, what's the stress level involved? Was my first thought about all those patients. But I do think there is something about, I similarly will see a lot of people who, I wish I could do research on this, but will say that they've had really, really kind of high-level jobs. And it's kind of an off comment they're making, but come to find out, they've really been involved in a succession level in their life where they've sort of made it in the job world, but it comes with a tremendous amount of being overworked, pressure, expectations set upon them, especially women in like maybe a male-dominated job, minorities and people of color who say that like they have to almost give like 110% to prove themselves. So yeah, I would say I don't know the research on that, but I do agree with you in that way.
So that was great. Do you do a formal depression screening at intake on all patients?
Yes. So we usually give the PHQ-9 and the GAD-7, and then sometimes our vestibular physical therapists sometimes do it first, which helps them understand who should come to psychology. They also give, the DHI, and then sometimes, I'm trying to think, like other kind of quality of life measures, but yes.
My headache neurologist has gotten really interested in these adverse childhood experiences, or ACEs, and they're screening in their headache clinic for those ACEs and finding correlations, and there's published research with that and disease severity. Do you screen for that, and do you see any connection between ACEs and vestibular disease?
Yeah, so we don't give a formal screening measure, but I do ask about it, and I don't always ask about it in the first meeting. So, I find the good thing about therapy is you can see people weekly and they'll eventually tell you, a lot of things going on, but sometimes it's really not uncommon that people with Meniere's and other vestibular conditions have reported a level of some type of chronic stress. Sometimes it is more childhood adversity, but commonly it's also something like, I was on a job for this many years and had a boss who was, I don't know what word they would use, but not a very nice person to work for, I'll say. So usually some level of chronic stress is seen and not uncommon to see childhood adverse experiences.
All right, well, thank you very much. All right, so now we're going to transition to our final panel of the session, and I really think this gets to the heart of why we're all here today. The topic is going to be barriers to Meniere's disease research, and Dr. Divya Chari is going to be our moderator.
All right. Hi, everyone. This is our last panel for today. I'm very excited to be here just a little bit longer, and then we can all go and have a drink and enjoy ourselves. So my name is Divya Chari. I'm an otologist in Massachusetts, and the topic of today's panel discussion is barriers to Meniere's disease research. So we are very fortunate today to have three really expert panelists with us. We have Professor Lopez-Escamez, Dr. Vambutas, and Dr. Eckhard, and we've heard all of them speak today. So just to begin with, I'd like to ask each of you just to share a few words about your journey to Meniere's disease research. What I'm really interested in is, if you can tell us a little bit about what you originally studied before you got into Meniere's disease research, and then really what helped you kind of focus your research into Meniere's disease. So maybe we'll just start right at the end. So Dr. Eckhard, if you can start.
Sure. Well, I guess I started out my research on Meniere's disease, or during my doctoral thesis in Tübingen, Germany, I worked on aquaporins in the inner ear. So there was from the get-go a relation to water regulation and ion homeostasis in the inner ear, and that expanded then later to cell pathology mechanisms on the ear using human temporal bone resources.
Perfect.
So I started my Meniere's disease research about 2002, I think. The reason for starting that is because I was setting in a primary hospital, starting to run a neurology clinic by that time. And I see that this patient has no specific treatment, no specific diagnosis. That was the kind of patients that nobody really wants to manage because it was a difficult task. That was the origin of the research for me.
So actually, I started by doing HPV research for my KO8, and I had an aha moment at one point. Jeff Harris had come to be one of our speakers at our institution for an annual otology endowed lectureship, and he said to me, it's really schizophrenic. If you're clinically an otologist, what are you doing HPV research? And I was like, you know what, you're really right. And so that really launched my decision to change what I did in the research realm, and started out by looking actually at cochlear implant patients with end-stage immune-mediated hearing loss and asking why are they different from people with stable hearing loss, and harvesting perilymph and stimulating their immune cells to get to where we are today.
That's great to hear. It's always nice to hear about people who have started in one area of research and then been able to transition, and people who have been able to kind of pick one and then move forward, because it's sort of, as you're starting to think, especially for early career researchers, as you're starting to think about what area you want to focus your efforts on, it's nice to know that you're not necessarily locked into one going forward. So Perfect. And I should have mentioned this at the beginning, but the structure of this panel is that we'll spend about another 10 minutes or so going through a series of questions that I've designed specifically for our panelists, and then there'll be time at the end for questions, so please save your questions for that as well. All right, so I just want to spend a few minutes discussing the evolution of our understanding of Meniere's disease. We've had a lot of really great talks over the course of this afternoon, really seeing that there's been just a really incredible transformation over our understanding of Meniere's disease, but there's still a lot that we don't really understand. And so, if we start from 1861, when Prosper Ménière first described the condition, and then 77 years later, when two researchers, Yamakawa and Halpike, independently identified endolymphatic eye drops as the histopathologic correlate of Meniere's disease. And then, it was another 35 years later that the American Academy of Otolaryngology defined the diagnostic criteria of Meniere's disease, and that was later refined a number of different times. And then there have been a number of different advances, maybe since then and maybe during that time period. So, Dr. Eckhard, maybe we'll just start with you. What I'm really interested in hearing is maybe you can tell me a little bit about what you see as the major advancements in Meniere's disease over the past 150 years or so, and how would you describe the state of our current state of our research in Meniere's disease?
Well, I would say the biggest leap came with evolution of time. The first concepts about what happens in Meniere's disease, starting from Ménière and then later going into the 20th century, were pretty much, I would say, formed by a mechanical understanding of how fluids move in the inner ear, how pressure evolves, and the therapies were then also designed to either release pressure, build in valves in the inner ear, or tackle basically a mechanical problem. And then with the advent of the molecular age, so to speak, we're now trying to understand that disease on a cellular and molecular level. And I think that was, I would say, the biggest leap.
Yeah, fantastic. Professor Escamez, Lopez, do you have any?
So I think that probably one of the biggest changes has been the identification, in my view, of familial clustering and Meniere's disease. That's something that was studied in, I think, 1945 or something like that. So that was the first description of the families. And the history that has been reported in the 60s, then in the 80s, and then we started to see that. So the familial clustering is something that is known for a long time, but the advance of exome sequencing and the application of that has made a big change, because now we can study this family. That has been also a big change in the identification of genes, and from that I think that we have made a great progress.
Mm-hmm.
So I think one of the other things that, and this is not just for Meniere's disease, but this is really in any pathology of the eye, brain, or inner ear. We used to historically think that there was a very tight either blood labyrinthine barrier, blood-brain barrier, and things in the peripheral circulation didn't get in, and things in there didn't get out. And we now know there's very routine immunologic trafficking of peripheral blood immune cells into the inner ear, into the brain, into the eye, and there are multiple evolved mechanisms to protect those critical organs. For instance, decoy receptors, which we really didn't talk about today, but they're basically immunologic sponges that prevent further downstream signaling, and that is one of the major ways of protecting those organs while still allowing that immunologic traffic.
Okay, so for the next question, one of the major challenges that we have in clinical research, and this has come up a few times today, is that Meniere's disease really has a natural tendency to regress and then improve over time. I'd like to know, maybe we'll start with you, Dr. Vambutas, at the end. How do you think that this will impact our clinical trials, particularly in being able to, address the efficacy of the treatments? And are there ways that you can think of that we can try and design the trials in the future, really to try and distinguish between whether or not they're effective treatments from placebos?
Yeah, so it's an excellent question, specifically for Meniere's disease, with a placebo rate that in some studies have been as high as 80%. And so especially if you're studying the vertigo component of Ménière's, it's incredibly challenging. For that reason, most of our clinical trials have really looked at the hearing response because the audiogram is definable and measurable from time, from point A to point B to point C. The vertigo aspect is a lot harder to design a trial. But then also from a recruitment standpoint, it's really important that you design a trial that you're not in competition with your other local otolaryngologists, and the most common example of that is the sudden hearing loss trial. When people were getting reimbursed a huge amount of money to do intratympanic steroid injections, no one wanted to refer in for the sudden sensory neural hearing loss trial. Trying to create a trial, you want to do one that is really not in competition with the people that need to refer the patients to you.
So I think that this is really the most important question if we want to advance in the treatment of Ménière's disease. The design of the clinical trial has to change entirely. I think that I would say most of the current clinical trial has very low value, and the reason is the selection bias. We have to define a biomarker when we are selecting patients for a clinical trial and measure the biomarker, and I'm talking something that we can measure before and after the intervention, because this is the only way that we can really assess the effect of any kind of intervention. Most of the clinical trial cannot rely only on reporting symptoms. Even from a point of view, we cannot understand what is going on in a specific subgroup of patients, because I want to insist this, Ménière disease is not a single disease anymore. We have to measure cytokines before. And we have to, if we think that this is possible, we have to design the clinical trial according to a specific subgroup of patients. And that's probably a big change, because all the current clinical trials are not selecting patients according to that.
Yeah, I agree with everything my colleague said. It comes down to a signal to noise problem, and reducing noise, or noise is introduced by the fluctuating, unpredictable course of that disease, and reducing the noise would mean longer follow-up times and so on. We heard about this. On the other side, increasing the signal means, I agree with Antonio, selecting subgroups of patients, being more aware who receives what treatment, and testing more effective treatments, cures, I think would also boost the signal.
Yeah, that's great, all great points. One of the things that occurs to me is, it's been brought up a couple times, I think Dr. Rizk brought it up earlier, this idea that if we could do multi-center trials, right, that would be better. Ménière's disease is an overall rare disease. We want to increase our overall N, especially if we're going to then start subdividing patients into different groups. One of the challenges that I foresee is that Ménière's disease has this very broad diagnosis. I get tons of referrals for Ménière's disease, and when I see the patient, I say, there's no way this is Ménière's disease. And the patient says, no, I've had Ménière's disease for the last 15 years. You don't know. And I'm like, no, this isn't Ménière's disease. This is migraine or whatever else. So are there ways that we can standardize that diagnosis? I mean, I'll pose it to any of you, whoever wants to take the question.
So yes, that's why I want to remark that we need to use a biomarker. For example, we can distinguish very easily patients with vestibular migraine from patients with Ménière's disease using biomarkers, measuring cytokines. And that would be a very important criteria. Patients with vestibular migraine never have high level of IL-1 beta. We know that. This is very rare. So if we can select a group of patients with high level of IL-1 beta, we were selecting probably active patients, and we know that this specific, let's say, immunophenotype can be specifically treated. This is one example, yes.
Yeah. All right, I'll move on just for the sake of time. That's okay. Moving on to basic science research, I've just posed a few different potential challenges for basic science research, though of course there are many others, but for me at least, I think about this ideal reality as being one in which we can obtain predictable results, have high reproducibility, and something that can really reflect the human pathophysiology of Ménière's disease, this fluctuating progressive hearing loss, decline of the vestibular function, things like that. My question for anyone who wants to take this is, what are potential ways that we can overcome some of these barriers? I mean, are we just sort of doomed to never have a reliable animal model? Are there other things that we can learn learn from animals outside of this, even if they're not a perfect match for what we see in the human version of Meniere's disease? And what do we do about the fact that we have sort of a lack of standardized biomarkers?
I think I alluded to that in my talk, and I think in much of the research we're doing at MASA and ear, we're dealing with that problem on a regular basis. Meniere's disease affects the entire inner ear, and just from a structural basis, it is apparent that the inner ear looks and probably works different than in the inner ear of rats, mice, and even lower species. So reproducing Meniere's disease as we see it in patients, in an animal, is one question. Is that possible at all? And if not, are we satisfied with animal models that reproduce only parts of the pathophysiology? And how do we make sure that this is truly part of the pathophysiology and not a pure correlation that we see in these models?
Yeah.
I think that's a challenge.
Yeah, go ahead.
I think that we have a solution for that, and the idea is going from human data to animal data. So what we have to generate a humanized transgenics model that had exactly the same mutation that we have found in the humans. We are already developing a double mutant autogenic mouse model that contained exactly the same point mutation that we have found in human. And we are inserting exactly in the human exome, try to resemble the same pathology. And this is probably going to represent a model that reflects the pathology that we have found exactly in 4 families. And this is something that if we are able to demonstrate the phenotype in this mouse, that would be really reliable. And we can use also, of course, that model for clinical trial and for gene therapy.
So I just have really 2 more kind of groups of questions. We're kind of nearing the end here, but just one quick question. Maybe I'll pose this to Dr. Vambutas. You mentioned a little bit about how your K08 was in a different topic. I wonder if you could just speak very briefly about, securing funding for Meniere's disease. Did you find that to be a challenge? Was the rarity of the disease an obstacle for you? How have you overcome that or circumvented that?
So, I mean, it's an ongoing problem because, quite frankly, today you cannot define Meniere's as a rare disease. It doesn't meet the criteria for rare disease and getting additional funding because part of the problem is defining the duration of disease, right? If you have a self-limited disease that ends, let's say, 6 months from now, it's fairly easy to very discreetly define the rare disease population. But for a disease that goes on and on for years and years and may wax and wane, it actually doesn't meet the criteria for rare disease, and so you don't get the additional pharma benefits of developing drugs for Meniere's because it doesn't fit the criteria.
Yeah, even though it has relatively low incidence.
Absolutely correct.
Okay, very last question for the panelists. If there was one major barrier to Meniere's disease research that you would like to see removed in the next 5 years, what would it be?
So I would say the recurrent theme that we've had all day today is one that we very tightly define these patients, and as we enroll them into trials, we really discreetly define who they are, what their cytokine profiles may be, what their responses to drugs are. In other fields, response or failure to respond to a drug is an entrance criteria for many trials, and it actually increases the homogeneity of the patients you're studying.
Fully agree.
Perfect. All right, be done there. So we can, if there's any questions, we can open it up to the audience for Q&A.
So I think we learned a lot today about how we commonly think about Meniere's disease as having several different causes, but interestingly, it leads to the same common clinical phenotype. And so I'm curious if, some of the basic research that you all have done has helped you understand why the disease causes vertigo and why it is episodic in nature.
You want to do this?
Yeah. Okay. Well, I'm going to refer to what I talked about today, and I think, in short, we don't have that answer yet. I think what I presented today is one part of the pathophysiology, and I think that's also one one challenge in our field that we at least have to be aware of. It's a complex disease. The pathophysiology are most likely a sequence of events with side arms merging into each other. And we're tackling, or it's most likely difficult to tackle the entirety of that pathophysiological process at a time. So breaking it apart is a necessity, and I think we don't have that answer yet.
So the symptomatology may be identical and similar, but the underlying cause of how you got to that symptomatology may be totally different. And if you look at the example of Cogan syndrome versus Muckle-Wells syndrome, Cogan syndrome responds to TNF antagonism very nicely. Clinically, it looks almost identical to Muckle-Wells syndrome, and yet in those patients, the treatment is use of an IL-1 antagonist. So your clinical symptomatology is where we get completely hung up. They clinically look the same, but the treatment is different. And if we try to apply the same treatment to all of these patients, we're going to fail miserably. So we really need to more clearly identify the underlying molecular mechanism that's causing the symptoms we're seeing.
So we have time for just one more question. Okay, 2 more questions. Come on up. We can take your question as well.
Great presentations and session. I'm an engineer, I'm not a clinician, so pardon if my questions sound like silly. So what I got is that it's affecting the hearing thresholds. Can you comment on some physiological biomarkers, electrophysiological biomarkers, which comes into picture before it affects thresholds, either like peripheral or central processing?
It's a great question. Unfortunately, I don't have an answer for that one.
Me neither.
Did you want to ask your question?
to understand the question.
Hi, this is not as much of a question as an announcement, just to say when we were talking about funding, HHF, we are going to have Meniere's funding. The deadline for submitting a proposal is, the letter of inquiry is going to be next Thursday. March 3rd is the deadline. We started in October, but we will have Meniere's funding this year. So if the grants are going to be $50,000 a year for 2 years, so it's a $100,000 a year, or $100,000 grant. So if that's something that you're interested in pursuing, please go to our website but that funding is available, and we are looking to increase the amount of funding that we're doing in Meniere's disease. So please follow us at hhf.org. Thanks.
Great. Everyone should get their applications in. All right, a huge thank you to our sponsors, the American Hearing Research Foundation, Cures Within Reach, and Hearing Health Foundation. This has been a really great session. Thanks.
All right, everyone, what a day. I've learned so much. I've taken a bunch of notes. I'm really excited to hit the networking session. Before we do that, just a few words of closing from the American Hearing Research Foundation.
Thanks, Claire. Good evening. I'm not sure this is working, but I will try. My name is Mark Munch. I have the... Oops.
I'm sorry. I just want to sneak in here. Put that up. Thank you.
I have the pleasure to serve as chairman of the American Hearing Research Foundation. I'm also the last thing standing between you and free drinks and hors d'oeuvres, so I will be brief. I'd like to conclude our symposium today by thanking all of the speakers, panelists, the researchers who presented today. I have neither a clinical background nor a research capability or background as well. But I found all the talks fascinating, and I really appreciated learning more about Meniere's disease and the impacts it has on people and all the good work that everyone is doing here. I'd also like to thank our sponsors and co-sponsors, Hearing Health Foundation, Cures Within Reach, VeDA, Spiral Therapeutics, and Scott Dorsey from Central Indiana. So thank you all for helping us put this event on tonight. The last thing I wanted to say is, any type of event like this, and I'm sure most of us have been involved in these types of things before, there is a small but usually very dedicated working group, steering committee, call it what you will, individuals who really work very hard behind the scenes to make all of this kind of happen. So I just wanted to thank them. Dr. John Oghalai, Dr. Anna Lizakowski from American Hearing, who serves on our board, Dr. Brian Ward, Dr. Divya Chari, who was just up here, Dr. Michael Hoa, Claire Thibodeau, Dr. Thibodeau, who works at Cures Within Reach, Chris Geisler from Hearing Health Foundation, and a special thanks to my colleague and good friend, Joan Wincheston, who up until 2 months ago served as our executive director at American Hearing Research. She has decided to have the audacity to retire on us. I will miss her, both as in a professional capacity as well as a personal friend. But I thank all of you for all the hard work that was done. I would get periodic updates from Joan and know how much work went into this. So thank you for all the work that all of you have done. Again, I'll ask and remind that if you can get a chance to snap our QR code and take our survey, we'd really appreciate that. Trish has tickets in for people who need drink tickets still, so she's in the back. You'll find her. Enjoy the rest of our symposium and our networking time tonight, and have a great ARO. Thanks again.